Thank you, colleagues. We are about to start. So if we may take our seats, I'm just trying to, I know that my glasses aren't failing me. I'm looking for Commissioner Nimataini, and I don't want to take the risk of starting if she's not yet seated, because she's one of the first speakers in the program. So if anyone has actually seen her, please, Asha, come Nimataini to actually come and take a seat. Right. Our distinguished guests today, the distinguished commissioners, the representatives of government departments, civil society, and women's organizations, the youth representatives, development partners, and all stakeholders joining us both physically and online. Good morning. On behalf of the Commission for Gender Equality, I just wish to welcome you. Yes, I'm not doing the welcoming, but I guess I can't start without starting there. I just want to welcome you to this important Imbizo, convened at a time when teenage pregnancy and adolescent pregnancy continues to demand a collective, evidence-based and rights-centered responses. So today's engagement is not simply about acknowledging the prevalence of teenage pregnancy, but it is about moving decisively from recommendations to implementation and from concern to practical solutions. The presence of stakeholders across health, education, social development, the police, justice, Department of Women, Youth and Persons with Disabilities, the National Prosecuting Authority, civil society, women's rights organizations, youth formations, and international partners such as UNFPA, and also the learners. I am so warmed. It is important, is really an important demonstration that this challenge that we are actually tackling today cannot be addressed by a single sector. It really requires a coordinated whole of society response that places the rights, dignity, prevention, safety, education, and future aspirations of every girl child at the center of our solutions. And this is why I said earlier on, my heart is very warmed at seeing the learners actually gracing our presence today. My name is Philisiwe Gabela. So I think just for the purpose of today's program, please call me Pili. I always find it easy if you use that tagline. I'm your program director, and so please stay with me. And those online, I really am asking you, colleagues, to really stay with us. We are really grateful that you've taken time to participate in this important National Teenage Pregnancy Imbizo. Others are going to say dialogue, others are going to say stakeholder engagement, and we really welcome all those names, and we understand that this engagement provides an opportunity to closely look at the factors that continue to expose girls to early and unintended pregnancy while strengthening a gender-responsive and gender-based rights approach to prevention and intervention. The task for today's panel, in my view, is really clear. That is to deepen the solution lens, examining what is working, confronting the gaps in policy and implementation. We also understand that this dialogue is going to strengthen accountability across sectors and develop practical prevention mechanisms that can be translated into measurable action, so that we can be able to meaningfully close and eradicate the conditions that perpetuate teenage pregnancy in South Africa. I'm also confident that as we shall critically listen to the young people, the teenagers or the adolescents or the learners today themselves, and ensure that their lived experiences inform the solutions that are going to be developed by today's engagement. As we delve into the proceedings, I'd like to encourage everybody to engage and appraise us. So here's how we are going to do this. We are going to have moments for broader question and answers as we move along the program. So the stakeholders attending online, please put out those questions and really engage us. And in between the speakers, if one has a question, kindly put up the hand so that we can acknowledge your question and those questions will be responded to. We're going to and so as we do this, I do acknowledge that we started a little bit late, 30 minutes behind the allocated time. So allow me, Dr. Oveni, to trim a little bit of 5 minutes of each speaker's allocated time. And I will actually just try and sensitize the speakers as they come up and come along, just so that they can be mindful that I'm going to just take that 5 minutes so that this can really be a robust engagement. And Imbizo, or a stakeholder engagement, I wouldn't imagine that we are going to have a program that is filled of, speaking or rather speakers without really engaging on what they would be engaging us on. So these questions, as I indicated earlier on, I am actually providing a commitment that they will be responded to. So moving along the program, colleagues, the program for today is as follows. I do want to believe that everybody has this program within the allocated packs that we have on our tables. If not, the technical desk is going to flash the program as and when we move along. As I said earlier on, we sincerely apologize for the late start. And we should have started by 9 o'clock by having Commissioner Mulalo, who is going to tell us broadly about the purpose and context of today's Imbizo. And following Commissioner Mulalo would then be Dr. Oveni, the head of research, presenting on data and trends in teenage pregnancy in South Africa. I tried my level best, Dr. Oveni, to stay away from what you are going to present, not come here and be talking the statistics, highlighting what you're supposed to be highlighting without getting much into detail of what the purpose of today's engagement is, Commissioner Mulalo, because there is a provision for that. And then followed by that item is going to be followed by Dr. Nonzuzo Mbokazi, who's our keynote speaker for today, addressing us on the theme, building a caring society. Followed by that would then be the Department of Social Development, presenting the aspect of teen psychosocial support and remedial interventions. So the Department of Social Development, you just need to be aware that we have learners in the house, because if we may have, as government, put out psychosocial support and remedial interventions that are not responsive to those learners who are sitting there, but believe me, they are going to tell us that that is not going to work, or they are going to agree with us that such interventions may work. And from there, we're going to take, I see that we had an allocation of about, 15 minutes tea break. We're going to trim that with like literally 5 minutes. So it's going to be a working tea break. We're going to just grab it, something to drink, and then we come back on our desks. And then followed by that, it will then be the Department of Health that is going to present on the health sector response and adolescent sexual and reproductive health, SRHR. Do they have a choice? They are going to tell us, Department of Health. Have you really accessed it? Learners are going to tell us. And moving along, we would then be the Department of Basic Education, a very critical stakeholder that actually, in our absence as parents or legal guardians, tends to be the parents for a period of like 9 hours a day, because they are with the learners true, and they are going to be presenting on the education, school retention, and support for pregnant learners and young mothers. How are they accommodating? Is there reasonable accommodation to accommodate the learners who are actually expecting. From that, we will then take a lunch break, which I see that it was meant to be about 1 hour, 10 minutes. I'm going to cut it down, colleagues, to 45 minutes. We're just going to grab and quickly eat, and we are going to digest that meal back into this room. From there, we will then have the Department of Justice, let me say the Justice Cluster, characterized by SAPS and NPA. They are going to be looking broadly into the gender-based violence, sexual exploitation, and teenage pregnancy. And they are going to be taking us along how they are actually responding onto these cases that constantly come at their doors. There may have been a bit of colleagues, some shifts that we are going to put along the Department of Women. DDG has actually asked for a little bit of some consideration because there is another engagement that she is actually equally double booked for, and then we are going to push a little bit forward. So please don't beat me, colleagues, if I do that. I don't want us to really lose that presentation because it is actually critical from an NSP point of view to hear what is the ministry actually responding, how is it responding on the matters. And then followed by that, we're going to be having the community or civil society representative looking into the family and social factors influencing teenage pregnancy. Along that will then be a youth representative looking at the youth adolescent voices and lived experiences. And that afternoon tea, again, it's just going to be another 5-minute break, just leg stretch break. And when we come back, we will then have the UNFPA. I don't know why I'm so tempted to put together UNFPA next to the Department of Women so that we don't lose that conversation, but I will be guided, colleagues, and they will be presenting on the technical support on the development of LENA pregnancy national strategy. From there, we will then open a broader stakeholder engagement, a dialogue as a response to what may have been presented or as enhancing what would be missing in terms of saying, look at that area. I'm making an example, Department of Women. We may do better if we were to do this. And we really encourage the learners to be very active when it comes to that, because whatever outcomes that we are putting out today are outcomes that must respond to their agency. And from there, we will then have Commissioner Samai, who is going to give us key resolutions and the way forward and closing remarks. And from there, we will then actually depart back to our spaces. Thank you so much, colleagues. And following this, I will then actually ask the Holiday Inn safety representative to actually give us some safety procedure so that we can be able to be appraised of how we are supposed to move when we need to do this and that. Over to you, sir.
Good morning to everyone from the Commissioner for Gender Equality, and thanks, Program Director, for giving me the opportunity to welcome everybody. I'm El Mongwenya, representing the health and safety team here at the Holiday Inn Sunside Park Hotel. So in the case of an emergency, you will there will be a siren going off, and there will be an announcement actually telling you how you have to go out. What you'll do is you'll use the nearest exit, which is marked on with our direction signs there by the doors. You lead straight to the car park. Also, there will be direction signs where you'll go straight to our emergency assembly point. Our health and safety team also will be with you, guiding you on what to do. And we have Godfrey there at the other side, our IT, and Brian and Tulani, who will be also closer to you during the process of your meeting, helping you with all your needs and also making us alert of anything that will be you will be requiring. And our bathrooms for the ladies will be on your left, and then the others for the gents is on our, through that door there where there is your tea. To your left again will be the area there. If it's congested, please use the prospect side outside the building. There is the other area where you can use your bathrooms. And your lunch will be in the Milner's restaurant next to our reception on your right. I thank you.
Don't be stingy with your hands. Thank you, colleagues. It is now my pleasure to proceed with the program. And as I think before I do that, let me also acknowledge the presence of our Chief Executive Officer, Dr. Dennis, in the room, who has just actually joined us. Good morning, CEO. So allow me, colleagues, to please proceed to the program. And now I invite our first speaker, Commissioner Mulalo, to make her way and actually do the welcoming. We're not even sure if we're, in the right room for the right meeting. And I think we may actually be given that opportunity to check if we are at the right place. Thank you so much.
Good. Can I get assistance with this? Perfect. Thank you. Good morning, colleagues. I think it should be fine. They can hear me. Good morning, colleagues. My name is Commissioner Muraro Nematayeni from the Commission for Gender Equality. I am here to do the purpose and context of the stakeholder engagement, but the program director asked me to welcome you as well, so I will do that. And from our side as the Commission for Gender Equality, we are saying welcome. Thank you for joining us on this very important engagement. Let me begin by putting the purpose of today's engagement into context. When we speak about teenage pregnancy, we're not simply speaking about pregnancy. We are speaking about a child, her rights, her dignity, her health, her education, and her future. The Commission for Gender Equality is convening this stakeholder engagement because teenage pregnancy remains a complex gender equality and human rights issue that requires a coordinated response. The Commission for Gender Equality is a Chapter 9 institution established in terms of Section 187 of the Constitution, and our mandate is to promote respect for gender equality and the protection, development, and attainment of gender equality. It is therefore within our mandate to examine how laws, policies, institutions, and social practices affect girls and women, and to identify where gender inequality is being reproduced. You might ask yourself, why is this conversation necessary? Too often, teenage pregnancy is framed primarily as a health or education problem, but our research and engagements tell us that the issue is much deeper. Teenage pregnancy is connected to gender inequality, poverty, unequal power in relationships, inadequate access to sexual and reproductive health services, gender-based violence, sexual exploitation, harmful gender norms, and unequal burden of care placed on girls and young women. We must also recognize that some pregnancies involving children may be connected to coercion, exploitation, and sexual offenses. Therefore, When we ask why a girl has become pregnant, we cannot only ask about her choices. We must ask what choices were available to her. Did she have access to appropriate information and services? Was she in a relationship where there was a significant imbalance of power? And most importantly, was she safe? This is why the Commission for Gender Equality believes that the response must be gender responsive and rights-based. Our 2023 CGE research, which our HOD will take us through, which is Learner Pregnancy Policy Interplay, examined dropout amongst adolescents girls during pregnancy and after giving birth. One of the concerning findings was that about 1/3 of the adolescent girls who fall pregnant return to school. 1/3 of the adolescent girls who fall pregnant returned to school. And this is significant because pregnancy can become a point at which a girl loses a connection to education and consequently loses opportunity for employment and economic independence. The problem is therefore not simply that a girl became pregnant. The problem is what happens after she becomes pregnant. Does the school support her? Can she remain in school? Can she return after giving birth? Who looks after her baby while she attends school? What psychological support is available? And what happens when the responsibility for childcare falls almost entirely on the young mother? These questions demonstrate why teenage pregnancy must be understood within the broader context of gender inequality and structural poverty. You may also ask yourself, why is the Commission for Gender Equality bringing stakeholders together? I am one person that believes that bringing stakeholders together works. I've witnessed it in the Northwest Province, where we would have a stakeholder engagement and some of the stakeholders were meeting themselves for the first time. And then when we have another one later on in the year, they would tell us about the programs and then initiatives that they have been working on together to ensure that gender equality and the protection of our children is in action. So from my side, we are doing this because we know it works and you are here to do the work. So we cannot address this issue in isolation. A young girl does not experience her life in departmental silos. Her health, education, family circumstances, safety, and economic opportunities are interconnected. This is why today's engagement brings together stakeholders from government, health, education, social development, justice, and law enforcement, civil society, traditional and community leadership, researchers, and importantly, young people themselves. We need to bring together the evidence and the lived experiences of those affected. The Commission for Gender Equality has undertaken research, investigation, and also provincial engagements, including our work in the Northern Cape and our engagement with the KwaZulu-Natal's multi-sectoral strategy on teenage pregnancy. These experiences have reinforced one important message. There is no single cause for teenage pregnancy, and therefore there cannot be a single institutional response. We also need to be clear that our responsibility is not only to respond to teenage pregnancy once it has happened. We must actively work together to prevent teenage pregnancy in the first place by addressing the conditions that makes adolescent girls vulnerable, ensuring access to accurate information and services, strengthening protections from violence and exploitation, and creating supportive families, schools, and communities. Prevention cannot be the responsibility of one department on one sector. It requires all of us to work together. This is why the stakeholder engagement is important. The purpose for today is therefore to create a space where we can collectively understand the problem more deeply examine the gaps in our current response, and strengthen coordination between the different actors responsible for protecting and supporting adolescent girls. The rights, dignity, safety, education, health, and future of the girl must remain central to our response. We must move away from a blame-oriented approach and towards a care-centered, rights-based, and gender-transformative approach. Because when a child becomes pregnant, our question should not simply be, what did she do? We should also ask, what did we as a society fail to do to protect her, support her, and secure her future? That is the conversation we are opening today. Thank you.
Can we put our hands together again? Thank you, Commissioner Nimataeni, for those profound opening remarks. And I think you are changing the conversation, in fact, challenging us to just think deeply from what we've always known, seen, heard. And you are bringing a very, I think, critical aspect of it, where you are asking, has a girl child been given a choice? And what kind of choice was it given to the girl child? And I think you are really challenging us to really think beyond what we've always, thought, and challenging us to confront the uncomfortable conversation and an aspect of choice. And I think the word choice is really very relative and very broad. And I hope that this engagement is really going to really open us to check what is it that we are doing right, where are the gaps, which areas can we strengthen, taking multi-sectoral approaches so that there could be a responsive and a right-centered approach into the matter. With that said, colleagues, I'm then going to be asking the technical desk that don't be stingy with music where necessary. You may sometimes just a little bit, but I think as we do that, then I'm gonna be then calling along our next presenter, Dr. Oveni, the head of department research for the Commission for Gender Equality, to come forward and give us a presentation on data and trends in teenage pregnancy in South Africa. Dr. Oveni, you actually welcome to come forward and take over the stage. And I do want to believe that the technical desk is going perhaps to flight your presentation whichever way. But I think as we are welcoming Dr. Oveni, I also want to ensure that we really acknowledge the stakeholders who are amongst us. I have actually been told that we have the Department of Women, Youth and Persons with Disabilities, actually represented by the Deputy Director General Meshogi, I was told. So we may then start to put the face onto the name. We may have had the name over, the online conversations, and we then have the department represented today. We also have the National Prosecuting Authority, the UNFPA. We have the Department of Social Development, the Child Care and Protection Services Directorate. We have Blind SA, and we have the Department of Health. We have the South African Human Rights Commission present amongst us today. We have DINOSA. So I want to believe that Department of Health, by virtue of us having DINOSA, is broadly represented. We have Dr. EDSD. You know, acronyms sometimes can be naughty, but we will unpack what this acronym is later on. We have the SENPACs amongst us. I was told the women's desk of the SENPACs is amongst us, really anchoring what you've actually challenged us to do, Commissioner Nimataeni, when you said we must ensure that stakeholder engagements continue to be done so that we do not work in silos. And I do want to believe that us having the St. Parks Women's Desk here is indicative of the fact that the entity itself is actually on a learning curve to just ensure that it collaborates broadly on issues actually affecting and issues that must advance women. And I will actually get into the list of who else is amongst us colleagues today as we move along, and I will continue to make those acknowledgements. With that said, welcome, Dr. Oveni. Over to you.
Okay. Ms. Program Director, Pili, HOD, PEI, thank you very much for the introduction. I also just want to greet our distinguished guests again, our stakeholders, our representatives from various government departments, our distinguished commissioners, our learners, and educators from schools around Johannesburg. I want to start by saying that I'm so excited to be standing here today and for this event to be fully realized. It was a vision of the research department, supported by the institution, of course, and for that, I want to thank and acknowledge the CGE Research Department. Commissioner Nemataheni has already largely started us on the discussion of today. So a lot of the things that she has already touched on, I probably will skip or I won't focus too much on. But I just want to say that it is impossible for us to have this discussion, all of us as stakeholders coming from different perspectives without aligning on certain things. So it is expected that some of the things that she might have touched upon, I will also present. This is the outline of my presentation. I think most of the stakeholders here are familiar with the CGE, but I will still take us through the CGE mandate to remind us why we are here. The Commission for Gender Equality is an independent statutory body established in terms of Section 187 of the Constitution of the Republic of South Africa. The CGE is mandated to promote respect for gender equality, the protection, development, and attainment of gender equality. The powers of the CGE are further outlined in the Gender Equality Act 39 of 1996. In line with this constitutional mandate, the CGE has undertaken extensive research, investigations, and stakeholder engagements on teenage pregnancy and its gendered impacts. Some of this research, investigations, and publications, I would like to believe that you are aware of. And I just want to highlight the learner pregnancy policy interplay that Commissioner Nemataheni was referring to. There is also a report on child marriages and child exploitation that was published recently, actually a couple of months ago, which also touches on a lot of the themes around teenage pregnancy. As Commissioner Nemataheni said, that teenage pregnancy is usually not the result of choice. It's usually the result of constrained choices, exploitation, as well as gender-based violence. So things related to child exploitation and child marriages are very relevant to the discussion. There is also another report of the CGE on Lena pregnancy in the East Rand of Johannesburg. This is a study that we are currently concluding with our partners, Section 27 and the Teddy Bear Foundation. However, a lot of the insights that are coming from that study are very relevant to this discussion. Commissioner Nemataheni also mentioned some of the provincial engagements that we have undertaken. I would like to mention the engagements we continue to have with the provincial department, the CGE's provincial department of KZN, on their multi-sectoral strategy on teenage pregnancy. And we assisted them with developing a human rights-based framework to assess the strategy in terms of its genderedness, let me rather put it that way. There were also numerous investigations. I would like to highlight the investigation into teenage pregnancy in the Northern Cape, which was undertaken to assess the extent of teenage pregnancy in the Northern Cape, as well as the response mechanisms intended to curb the scourge by relevant government departments. So drawing on this body of knowledge, research reports, provincial investigations, as well as stakeholder engagements, we have called you here today. We have convened this Imbizo to advance a care-centered, rights-based, and a gender-transformative response to teenage pregnancy. Dr. Mbogazi, our keynote speaker, I know will speak at length on this care-based approach to understanding or making sense of teenage pregnancy. However, in my presentation, I will also touch on some of these things as we collectively make sense of this problem. We have invited you as valued stakeholders to come and engage on this conversation. And there are some questions that, as we were preparing for this engagement, were at the top of our minds in terms of what your various departments are doing. So from the Department of Health, the Department of Basic Education, the Department of Social Development, the NPA, SAPS, we have some questions that we are posing and we would like to engage you on, which I have just projected. Questions around the National Department of Health and their termination of pregnancy services, mechanisms to track implementation or standardize access to termination of pregnancy services, proper record keeping in terms of also of termination of pregnancy services. What are the budgetary implications? I think one of the CGE reports recommended that the Department of Health consult the National Treasury to standardize funding models for termination of pregnancy services. The Department of Basic Education is also addressed, as well as Department of Social Development, South African Police Services, to spearhead school-based and community programs for learners. We also ask questions around what are the steps taken towards the retention of pregnant learners during pregnancy and postpartum. The CGE has previously recommended that the application of the national policy on the prevention and management of learner pregnancy be accompanied by programs that create academic support for pregnant learners and adolescent mothers in the form of catch-up initiatives and remedial actions. So to our stakeholders, I would just like you to have those questions at the back of your mind It is not an examination, so we will not be marking you on that or expecting that you respond to all of them. But I think these are questions that will help us to frame the discussion. Commissioner Namatahene has already summarized the problem. We know teenage pregnancy is a national crisis. It's a major public health issue affecting young girls and young children. The CGE's Learner Pregnancy Policy Interplay Report of 2003 cites inadequate sexual reproductive health services and the lack of parental guidance in this area as contributing to teenage pregnancy. However, we know that teenage pregnancy is both a cause and a consequence of structural inequality disproportionately affecting poor, rural, and marginalized girls. The CGE's 2023 report found that only 1/3, as Commissioner Mulalo has already mentioned, of girls returned to school. I would like to stress that adolescent pregnancy, as I've already said, is generally not the result of deliberate choice, but it rather stems from the lack of choices when it comes to marriage and contraceptive use in the context of coercive relationships, which is why gender-based violence and child exploitation are key drivers of teenage pregnancy. This is some data from UNFPA. I believe they are in the room. I was looking at the data because during the festive season, there was this idea that there was a spike in teenage pregnancies in South Africa. So I wanted to look at the data because firstly, teenage pregnancy, as you would know, is measured by the average fertility rate, that is births per 1,000 girls in a particular age group. So when there is the notion that teenage pregnancies have spiked, it's quite interesting to me because these kind of variables, they change slowly. Therefore, to look at this on a quarterly basis is probably not useful. One wants to look at it over a couple of years. And this data is quite useful to look at the trend in teenage pregnancy per province over the last 5 years. And it looks like the numbers are coming down. This was quite interesting to me. And I think we ought to ask ourselves, why is that the case? Are the numbers coming down because teenagers and adolescents have access to sexual reproductive health rights? Or are the numbers coming down because of termination, in that context, also access to termination of services? So this is all the data from UNFPA. I also just want to remind you that South Africa's teenage pregnancy rate, as measured by the average fertility rate, is one of the highest in the world. If you look at a global map, we are the highest in the world. So this is quite concerning. And a lot of people, when they see these numbers, 70 or 60 per 1,000 girls, are tempted to say, that's not a lot. But it's not an issue of the numbers themselves, but the issue of the consequences and the impact of teenage pregnancy on the pregnant learners, on their children, and intergenerationally as well, so that we talk about intergenerational poverty, especially among women. So having had a sense of what the data looked like, I wanted to present a little bit of our framework in understanding teenage pregnancy. This comes from our report on learner pregnancy in the East Rand. We developed a framework which draws on the capability approach. This is a famous theory of Amartya Sen. And this capability approach talks about capabilities, embedded or afforded to individuals as well as learners. But the usefulness of this capability approach is in moving us from questions such as, why did the learner become pregnant? To questions such as, what opportunities and freedoms did the learner have to make and act on reproductive, educational, and life choices? So we move from blaming the individual. We move from blaming learners to looking at the structural issues that affect learners. We also incorporated a human rights-based approach. Commissioner Molalo has already spoken about that. And this is looking at learners as rights holders. And I'm so glad that we have with us today the Department of Women as the lead department in this area, the Department of Health and Education. But we need to think of learners as rights holders, rights to education, rights to health. And I see, I hope the learners are taking notes and they can conceive themselves as rights holders, people having certain rights. Right to dignity, right to equality, right to make decisions about their own health. So we combine this capability approach and human rights-based approach to come up with a framework that not only focuses on learners as rights holders, but also on duty bearers, the Department of Health, Department of Education, Department of Social Development, and their duty towards learners in terms of their various services that they provide to learners. And we think this is a useful way of framing the problem and having this conversation today. The rest of my presentation, I don't want to take up too much time because I think there are other people apart from me who need to speak. I just wanted to highlight some of the findings that come from one of our studies, our most recent study. And these are qualitative studies, so they provide rich data on experiences of learners such as the ones we have in the room today. You know, so findings around limited reproductive agency. So we found something very interesting that most learners, when you go to a school and you interview learners, they are very knowledgeable about sexual reproductive health rights. They know you can go to the clinic to get these services. So knowledge is not the problem. And this brings us back to the issue of capabilities. Knowledge is not the problem. The problem is that despite having knowledge, they still don't act. And some of the findings we found also is around peer influence. So they're influencing each other, and there's this idea that, you know, contraceptives will make you fat or they will make you bleed heavily and so on. So we found that to be quite interesting, that knowledge is not the issue, but maybe the right kind of knowledge that intersects with their own experiences could be the issue. We found that families generally struggle to speak to teenagers about pregnancy and sex. We found crucially that that there is an issue around gender and relationships. So learners, young girls generally find it difficult to negotiate condom use with their partners. We found that relationships between learners and young boys of their age tends to result in better equality than relationships between young girls and older men. So thus we say teenage pregnancy cannot be explained simply as a failure of knowledge or individual responsibility. It reflects constrained reproductive agency within an equal relationship. We looked at some health care system barriers that for the Department of Health. So you're being charged by healthcare workers, long distances to clinics, stock outs and unavailable pregnancy tests, you know, inconsistent and unfriendly adolescent services. And then, of course, socioeconomic vulnerability shaping learners' access as well. We wanted to also reflect on the comprehensive sexual education program. And we found that sexuality education provides information, but does not always translate into behavioral change, which is interesting because If that does not result in behavioral change, then one wonders whether it's effective. Social norms and stigma. And then this is my last slide. Generally, pregnancy creates emotional and educational vulnerability, but support changes outcomes. So this is the other interesting thing that comes out of our study, that those learners who are supported either by a teacher, a parent, a father, an aunt or something, they have better outcomes. They go back to school, they have support, they have someone to look after their child, and therefore they generally succeed. So support came out as a crucial variable. The educational consequences of teenage pregnancy are mediated by the availability of social, economic, and institutional support. So access to services, but also income in order to travel and all of those things, and institutional support from the schools. The greatest challenge is the gap between formal services and meaningful access. So just having formal services doesn't always translate into meaningful access based on what I said earlier around the stigma, being judged by healthcare workers and so on. Learner pregnancy does not eliminate aspirations, we find. What threatens those aspirations is the absence of enabling conditions that allow learners to convert their aspirations into real opportunities. Thank you very much.
Thank you, Dr. Oveni, for that scientific presentation. That really looked broadly into the contributing factors and what we may not have seen or heard. It's your presentation, I think, is well-rounded because it doesn't just give the picture of what CGE found. I like the fact that you even went outside of looking at what the UNFPA says in relation to the scourge of teenage pregnancy that we find in the country. And I think what I take out from the presentation is the aspect of support and care that is actually coming out as a strong recommendation out of the CGE study. And as to whether this support and care is really provisioned is something that I think learners may actually want to indulge us on, because I think it speaks to the issue of better outcomes that we tend to see as the society when children are better supported and guided and taken care of. With that said, I'm going to ask us to just put our hands together once more for the presentation. And as we do that, we will then be, thank you, we will then be actually calling ahead, or rather calling forward Dr. Nonzuzo, our keynote speaker, who is going to be addressing us on the aspect of building a caring society. However, before, as we are actually having Dr. Nonzuzo, I just want to go briefly into her bio so that we can understand who Dr. Nonzuzo is, so that we can even relate better, or rather even follow her for that matter. I know that people are on LinkedIn, people are here and there, and we may need to really take along her thoughts long term. And that's why I'm just going to go through a little bit of her bio. And as I was sitting here, someone said, Pili, please loosen up a little bit, understand we have the youth here. So you may want sometimes to just acknowledge the fact that we've clocked it. So I'm going to just ask us to just clock it, clock it, clock it for the learners, and clock it for Dr. Nonzuzo. So colleagues, Dr. Nonzuzo Mbokazi holds a PhD in sociology and a postdoctoral fellowship in medicine from University of Cape Town. That balance. She's a sociologist and public health researcher with a profound commitment to addressing health disparities and promoting social justice. Dr. Nonzuzo's research spans the intersections of race, gender, class, and health. She lectures on public health dynamics in Southern Africa at the Institute for the International Education of Students. In the Befallen year, she completed her term as a research fellow at Arise Network Studies Center for Research in Health Systems, University of KwaZulu-Natal. She has served as the senior researcher for the Family Caregiving Program at the University of Cape Town. The program is a research study that adopts a qualitative, longitudinal, exploratory approach to understanding family care in South Africa, Botswana, Namibia, and Malawi. This is the first major program dedicated to understanding family care of older persons in South African region. Dr. Nonzuzo is a passionate advocate for community health, gender equity, and the recognition of the care economy. She has experience in collaborative work with various organizations to develop context-sensitive health interventions, contributing to the field through her work on health inequities, examining how systematic racism and social determinants impact the health outcomes of marginalized communities. Her research has been published in peer-reviewed journals and has influenced public health policies aimed at reducing disparities. Colleagues, can we then put our hands together for Dr. Nonzuzo Mbokazi?
Thank you so much, technical support, and thank you, Program Director, for that introduction. And a very good morning to everyone, morning to our students. Just to reassure you that I'll make sure that I don't lose you in this presentation. We can't have a conversation without you. But I'd just like to send a very warm good morning to all of our stakeholders this morning. I am excited to participate in this conversation, and I am excited to be in a room with all of the people that we're always writing papers that we need to engage with. We need their contribution. So to be in a space where everyone is here is truly great. And this morning, I'm going to be speaking about the care economy and building a society that centers and focuses on care. And just to get started on speaking about care and the care economy, it's important for us to understand that when we speak about the care economy, when we speak about social reproduction and the responsibility that we all have to provide care and to build a caring society that in this context, for the purposes of this conversation, centers adolescents and their reproductive health rights, we need to understand the feminist perspective, the feminist lens that has brought forward this idea of social reproduction and the care economy, and what we can think of and how we can think of building strategies that focus and center care. And just to unpack what we mean about the caring economy, it's important that we understand what care means, and care can be understood as what is paid and what is unpaid. When we think about paid care work, you can speak about our health workers, our health professionals, and the work that they do in clinics, in hospitals. So these are the people that are at the space of engaging with adolescents when it comes to their reproductive rights, whether they're going to the clinic to access contraception, whether they're going to the clinic to inquire about termination of pregnancy, which is them exercising their right, that freedom that they have to access these care rights. This is how we can think about paid care. And when we are talking about unpaid care, this is care which is often unseen. It's invisible care, which happens within the household. Maybe it even happens within the classroom, where teachers go that extra mile of providing care for adolescents and ensuring that adolescents are receiving the knowledge, are receiving the education and the support that they need when it comes to their reproductive rights. So this is just for your understanding about what we mean about the care economy when it comes to paid care and unpaid care. And then it's important to understand that caring or building a caring society has often been feminized. So it's often been women who have been centered as caregivers in society. And we can attribute this to socialization, how we're socialized, how care has been seen as something that's innate and something that is biological for women. But I would like to bring forward thinkers and scholars, research scholars within the space of care, who say that care is not biological. We all have the capacity, the propensity to care because we're human beings. We can care. We are all independent. We all have the ability to provide care. And in South Africa, it's a perfect context because of the spirit of Ubuntu. We all have this responsibility to provide care. You don't have to have a certain requirements in order to be cared for, but we exist in a context, we exist in a society that puts this responsibility for care on us. And I'd like to go further to use the context or experience of COVID-19. We saw how interdependent we are as the South African context or the South African society. We realized that we all need each other in order to function, in order to perform our rights, our responsibilities, our duties. And we saw how this can be restricted when certain rights that we have can be restricted, as they were during COVID. But what COVID taught us, or what COVID showed us, was the fact that we all have a duty to care. And of course, during this time, there were people who needed care more than others, but the crux of it when it comes to looking at care and the care economy and using COVID is the fact that it showed us that we all needed care. Everyone was nervous, and what it showed us was that we all need one another to exist. So when you think of that principle of Ubuntu, which is so fundamental in our context of umuntu ngumuntu ngabantu, it's been translated to mean I am because we are, but that translation doesn't really capture what Ubuntu is. It has a deeper minutia that we all need to understand in order to understand why it's important for a caring society and the care economy to be centered when it comes to thinking about teenage pregnancy. And just some core principles of the care economy is that social reproduction, I've already spoke about social reproduction and power relations. So when I spoke about researchers and thinkers who have spoken about the fact that care is not biological, we all have the responsibility to care, we all have the capacity to care, we then need to think about power relations and why the responsibility, the duty to do care, especially something like unpaid care work, why has it been put on women? Why is this responsibility when it comes to teenage pregnancy put on women? There's some data that I will get to where I had the opportunity to speak to adolescents, teenage adolescents in Umlazi Township in KwaZulu-Natal. And what came up in this conversation was the fact that the responsibility, the onus to ensure that teenage pregnancies aren't occurring was put on the female adolescents. Why is this? As adolescents, I call you to think about that. Why is it that so much responsibility is put on women, is put on female adolescents to ensure that the numbers of teenage pregnancies, which are increasing in South Africa, are decreasing? It's not, we can't just see male adolescents as autonomous when it comes to sexual reproductive care rights, but we need to bring them to the conversation and find a way to look at female adolescents as having autonomy as well. And this can happen through us looking at power relations and why power relations look the way that they look in South Africa currently. And then intersectionality is important, especially in the context of South Africa. We have experienced colonization, we have experienced apartheid, we have disadvantages, historic disadvantages, we have disadvantages based on race, based on class, based on gender. So this is something that we need to continuously be thinking about when it comes to teenage pregnancies and the feminization of poverty. Our research, our statistics are showing us the people who are shouldering poverty, as the president, our president, Cyril Ramaphosa said in one of his speeches, poverty in South Africa has the face of a woman. Why is this? And how can we undo this? What are the tools that we need to deconstruct this and create a caring society that brings women to the forefront and changes that face? I'm not saying that the face of poverty needs to change from being that of a woman to a man, but in building a caring society, we need to think of building a society where no one is shouldering this responsibility of poverty. There needs to be equal redistribution of care, of work that happens in the private space and public spaces as well. Invisible work. I won't hone in too much on this concept because I've already touched on it, but invisible work, which is the work of cooking, the work of cleaning, the work of ensuring that children are fed, of ensuring that reproduction to reproduce adolescents or children for the next day, for example. So we're focusing here on the work that happens before your classes start from 8 to, let's say, 2:30, and what happens after. So this is that invisible work that happens. And here I have cited Prof. Benya from UCT, who has written about the invisible economy. When she writes about the invisible economy, she writes about it in the context of the mining economy and the work that women do, the work that women have to put in to ensure that this reproduction is happening, because you can't just say you care and it's enough. As long as you get to school, it's okay, but that quality of care is important as well. And drawing on work that I've done in KwaZulu-Natal, mothers speak, for example, on how I can't just send my child to school looking anyhow, because I have to ensure that she looks appropriate, that he looks appropriate. So this is the invisible care work that this concept is trying to touch on. And this work is unpaid. It's not counted in our GDP. And other economic researchers have said that if it was counted in our GDP, it would count for a substantial amount, but it's not. But what's important in looking at this concept and looking at care and building a care economy is that this invisible work is happening, and it's important. It's key. Okay, and I've already touched on care. This is the different facets of care. So caring about, taking care of, and wanting to relate this to care within teenage or adolescent pregnancies. So this is where we can come. So we are having a conversation this morning about teenage pregnancy, and this shows that as different stakeholders, as the state, as researchers, as teachers such as myself, we care about the fact that our stats are showing us the increase of teenage pregnancy since 2021, where there was an increase of teenage pregnancy at 80,000. And again, in 2022, it was around 80,000. And then last year as well, this keeps increasing. But as our opening speaker, Dr. Hoveni, has said, there are also spikes. So we have holidays which spike teenage pregnancy or adolescent pregnancy. It's in patterns, it's in trends. So we can't just have one cause as to what is causing teenage pregnancy, but it's important for us to understand that it's happening in trends. And there are a lot of reasons as to why, and this is what qualitative research tries to do. It's to put an explanation to the numbers, to the figures. The competence, I'd like to touch on this point about the competence of caregiving. So the adolescents that I've had an opportunity to speak to in Cape Town, in Durban, have spoken about the fact that they have this fear of accessing healthcare services because of the attitudes that they often receive from healthcare providers. So work needs to go into ensuring that how healthcare providers who all of the time are older than adolescents substantially are not projecting their thoughts, whether they are conservative, whether they have negative thoughts and opinions about adolescents accessing contraception or inquiring about abortion. The fact is, adolescents have rights. They have sexual reproductive health rights that afford them the right to access contraception or to have an abortion if they desire to. And we have a history in South Africa that has shown us the importance of having rights such as an adolescent being able to access contraception or an abortion. So in 1975, we had the Abortion and Sterilization Act, but this act, unfortunately, didn't count for Black women. Only white people, or I should say people of color, didn't have access to reproductive health rights during the passing of this legislation, which is why it's so important that we have rights that allow adolescents to exercise that agency when it comes to their sexual reproductive health. And then in 1996, we had the choice on termination, which then gave women of color that freedom in order to be able to access and perform terminations. And that came from the fact that in 1994, 1995, there were a lot of incomplete abortions that were reported. This means that a lot of women were having abortions illegally because they didn't have that right to access reproductive health rights, because there were people of color who were disadvantaged under the apartheid regime. So this change is substantial. It shows progress. It shows how progressive our legislation, our law is, and much credit needs to be given to that. And it speaks to the importance of such spaces which try to echo that responsibility that we have to ensure that young people who are adolescents, who are still needing support, who are still needing guidance, are aware of their rights and know what mobility and agency they have. Okay, and I think just to be mindful of time, I think this slide is just to paint the picture globally in terms of stats, but Dr. Hoveni has done the statistic arrangement or what stats look like in South Africa. So just to paint a picture globally, it's important for us to understand that sexual reproductive health rights and the access of this is a problem. 80% of pregnancies that are happening globally are unintended, and 45 million of those end in abortion, which shows that they are unintended. And it's important to understand that being in the context of the global south or a developing nation such as South Africa, we still have a lot of disadvantages. We need to understand the geography of disadvantage which exists between urban and rural, and how this disadvantages people trying to access sexual reproductive health rights. For example, I'll draw from work I did in the Eastern Cape, where in 2021, this was right after the first wave of COVID, where adolescents that we spoke to spoke about the fact that we haven't had contraception in the Eastern Cape since the start of the year because of the disruption that COVID caused. They couldn't access reproductive support. So this in the Eastern Cape contributed to a rise in adolescent pregnancy. So this is just to paint a picture that when we look at the stat that 50% or less of women, of females trying to access contraception, this is not met, this is not realized just simply based on where their realities are, where they exist. So this is how space has an impact in terms of how you are able to access your reproductive rights. And then here I have already spoken about the history when it comes to sexual reproductive rights and the history. So the first block or first image is that legislation that we had in 1975, which disadvantaged women of color. The second block speaks to what we then have with the realization of democracy, this choice on termination that exists still in South Africa. And in 2020, with the realization that we still need work to be done on SRHR and how women are understanding this and how women are accessing this, this policy or legislation was then introduced, which centers the rights that women and adolescents have and the responsibility for the different sectors which exist to forefront this and ensure that this information is getting to women, it's getting to adolescents in order for them to understand their rights and access and you know act on their rights. And adolescent pregnancy in South Africa, just to paint a quick picture of it, it's 5 times higher than in other countries in the global north, and the rates remain very high. Yes, there have been decreases. In the presentation that we had earlier, it speaks about the fact that there has been a decrease, but still it's not substantial enough. There is still clearly a problem that is happening when it comes to the rights and how adolescents understand their rights. And persisting vulnerabilities is the fact that poverty and structural violence, which we can understand through the lens of poverty, which speaks to the fact that the conditions in which a lot of adolescents find themselves in force them into these relationships where an adolescent adolescents I spoke to spoke about the fact that it's survival for me. You know, it's me ensuring that there's something I can put on the table for me and my siblings because it was a child-headed household. So we have men who take advantage of vulnerable girls or vulnerable adolescents, which contributes to this rise that we see in teenage pregnancy. And we need to think about the responsibility that these men have to be held, accountability needs to be held by these men to understand that what they're doing is unlawful. It's illegal, and it's morally not ethical to be taking advantage of an adolescent just because you understand that their background is that of poverty, a cycle of poverty, because you are in essence also contributing to that cycle of poverty because the adolescents will fall pregnant and they will have to drop out of school. And I'm using this one example of how things unfolded for her. She fell pregnant, she then had to drop out of school, and the cycle of poverty then continues in this household. So there's a lot of responsibility, a lot of law enforcement which needs to happen when it comes to men who take advantage of adolescents. And hotspots for adolescents or teenage pregnancy, the rise of teenage pregnancy, are KwaZulu-Natal, which is where I have worked, and the Eastern Cape, which is also where I have worked. And if you know anything about these two provinces, is the fact that KwaZulu-Natal is 70% rural. So there are a lot of adolescents, female adolescents, who are existing in these spaces of poverty that are marked by geographical poverty and then disadvantage them. And also in the Eastern Cape is about 75% rural as well, which also paints this picture as to why or how we can understand this increase in terms of adolescent pregnancy. And just implications, I've already touched on these, about the health system and the work that has to go into understanding and making sure that healthcare professionals are not unapproachable. We need to create youth-friendly health spaces in order for young people to access care more easily, and gender equity. So we can't just see boys or males as autonomous and females as having this duty, carrying this burden to ensure that adolescent pregnancy is not happening. The duty, the onus, the social responsibility, the care responsibility, the ethical responsibility is on everyone. And I won't go into too much detail about this slide, but here I was just trying to stress the additional work that adolescents, female adolescents in a rural setting have to carry as well. And we need to look at iron deficiency because of menstrual poverty that happens in rural contexts. It's something that female adolescents have to deal with and cope with, and socioeconomic households as well. I've used that example of an adolescent who got into a relationship with a man who was 15 years older than her and she was 14. And this speaks to that reproduction of poverty, that cycle of poverty, which we need to work towards undoing. We need to have this care responsibility of ensuring that there's more of an equitable society that we're building in South Africa if we are thinking about building a caring society and a caring regime. And then there are also tropical diseases that female adolescents have to deal with because there's no running water in some rural areas in South Africa. This means that water needs to be carried or collected from a river, which comes with its own array of disadvantage, which leads to tropical diseases such as FGS and socially or culturally, female adolescents have to carry this burden of being shunned in society because this condition is not understood. They will often receive comments such as the fact that they are being promiscuous, they're being loose, when it's just the society that they're existing in which doesn't allow them these basic necessities such as clean running water, which has a contribution to their sexual reproductive health. And community health workers are often ignored. I think community health workers only started receiving payments like remuneration in the past 2 years, but the work that they have shouldered is a lot. So in the rural area that I worked in KwaZulu-Natal, I had the opportunity to speak to a community health worker who spoke about the fact that she had been managing a lot of cases of teenage pregnancy. And what she spoke about is the fact that these teenagers were existing in houses that were marked with poverty. So this speaks to structural violence and poverty and the impact that this has on adolescents. Pardon? Time. Okay. Okay, and we have a multi-sectorial strategy which was signed off last year on the 8th of October in KwaZulu-Natal, Potchefstroom. I had the opportunity to attend this, and it was great to see our Premier speaking. Sure. To see our speaker, our Premier, speaking about sexual reproductive health of adolescents and the work and attention that is needed in this context. And also, I'd like to touch on culture and the role that culture plays on teenage pregnancy as well. So we have Uktwala, which the work I'm drawing on was conducted in Zwelibomvu, which is a peri-urban area in KwaZulu-Natal, just outside of Pinetown, if you're familiar with that part of Durban. And the adolescents here spoke about Uktwala, which is loosely means to carry, but to explain it, it speaks to that marriage by abduction, which a lot of adolescents have to face, that a lot of adolescents still are victims to. And I'd like to share what an adolescent said. She says, he came on Friday when I was coming to collect my grade 7 report from school, and he abducted me in broad daylight. I tried to scream, but that was to no avail. No one cared. It was in vain. So this speaks to how cultural practices or the misuse of or the abuse of cultural practices has a contribution to the rise and increase of teenage pregnancies in South Africa. And another one said, when I discovered I was pregnant, I stopped attending school. I had to continue with my duties. My tummy kept growing. I didn't understand what was happening with my body, but I was advised by his mother, which means her mother-in-law, that I had to stay at home and attend to my responsibilities as a wife and as a mother. So when we look at cultural practices such as Uktwala, which are predominant in Pentecostal churches and traditional churches in KwaZulu-Natal, how do we think about care? Crimes such as rape, such as kidnapping, the freedom of movements is protected in Section 12 in South Africa. So how do we understand this? How do we build a caring society when we think about this? And just to close off, my final slide was about the ethic of care. Care is an ethic, and we all have a responsibility as all of the stakeholders in this room to care. So the care receivers in this setting are the adolescents, and the caregivers are all of us as the stakeholders, and we all have a duty, a responsibility to build a caring society. Thank you so much.
Thank you for that presentation, Dr. Mbogazi, and I think we can again give another round of applause to the presentation, which is very educational. In my view, Dr. Mbogazi, touching on the disparities that are out there, and of course, grounded in research. And I think you broadly touching without me, rehashing your presentation, but I think as a key takeout, your presentation, you are really pushing us towards the aspect of accountability, actually, imploring us to find youth-friendly approaches and provide such spaces so that adolescents can have autonomy. And that to me is a takeout of your presentation to say that everybody who is actually sitting here, according to the law, is a caregiver, and therefore the receivers ought to be protected always at all times. And I think this really takes us to the aspect of just planning, and I think within the context of duty bearers, the planning, is your planning care-based? Is it care-centered? Is it really favoring the adolescents? Is it centering them? And your presentation, it really actually, implored us to do just that. And I think, again, we can just say, again, clock it, Dr. Nonzuzo. Dr. Mbogazi, clock it. Clock it. As we move along, colleagues, I would like to just implore us to follow the Commission for Gender Equality on our social media pages. On X, you can follow us at CGE_ZA, and on Facebook, we are the Commission for Gender Equality. And I am going to just ask the technical desk to continue putting out the what do you call the WhatsApp link on the screens so that we can be able to just scan it and then continue to follow the conversations. And also, if we were to look into the program at the bottom, we are then going to see that we can then just scan the QR code at the bottom of the pages. And this code is going to take you directly to our WhatsApp channel. And the channel is really packed with very progressive information. You will then be able to follow us and actually pick up daily what is it that the Commission is doing. And this is where you will find broadly the implementation of our programs, initiatives that are happening, whether at a national or at a provincial level. You will then be able to find that information and follow us live, real time, if you are to actually follow us. And moving along, colleagues, I am told that if you were to just put on your Google hashtag Teenage Pregnancy Imbizo, and you then actually post whatever thought that you may have, be it this is on LinkedIn or social or any social media page, you will then be able to actually advance the conversation and tag along others who may actually give us, a broader perspective of what we may not be seeing. Moving along, colleagues, on with our program, then I am going to then ask Department of Social Development to come forward and give us a presentation on the teen psychosocial support and remedial interventions. And this presentation is going to usher us into a short tea break so that we can have some body break, stretch, and attend to our bodies. And colleagues, we may then just put our hands together for the Department of Social Development. Thank you.
Good morning to my learned colleagues, and a very special welcome to our learners. And thank you for being here. So you also are able to see exactly from the Department of Social Development, how do we render services to young women, young girls, and children that are faced with teenage pregnancies in our schools. My presentation, please. There we go. Use that one. All right. All right. Let me first introduce myself and tell you who I am. My name is Yvonne Dionarine. I work for the Department of Social Development, and I work in a unit called Childcare and Protection Services. My role is very critical in the sense that I deal with all legislations and policies that govern how child and children's services should be rendered. So the basis and largely it's within the Children's Act, and that informs how we regulate the sector in terms of children's services. But today's presentation largely focuses on how do we respond to teenage pregnancy, which is a growing problem within our schools. And many young women, young girls, children are faced with having to become young mothers at a very young age with little or no support, and obviously compromising the quality of their future. I would not be, doing justice if I didn't talk to the fact that child pregnancy or teenage pregnancy, largely when we look at it from a child protection perspective, links to statutory rape. And therefore, you'll see my presentation starts with exactly that if we do find our young children, our young girls pregnant, we ask ourselves the question, have they been victims of statutory rape? Have they been exploited? And therefore now find themselves to be teen mothers. Let me try and get to that. All right. So the first part of my presentation will look at statutory rape as a criminal offense. And I know I have my learned colleagues here who do know the Sexual Offences Act, but I'm just going to touch on it so that I'm able to compare and show you exactly what and how social development intervenes. In terms of the Sexual Offences Act, we all know the Sexual Offences Act talks about as in place to protect all individuals from sexual crimes by providing a comprehensive legal framework in responding to sexual offences. The Children's Act is put in place to protect the rights of children. And if young children or a child or a teenager is being exploited and become pregnant, one would ask the question, has this child been a victim of sexual exploitation, and therefore would be seen in terms of protecting her in terms of the Children's Act, but also to look at the act in terms of it being a criminal offense. Now, statutory rape. Statutory rape refers to a legal term that defines sexual activity between two individuals, where one is below the consent age of 16. We are seeing more and more of these kind of cases where you have young girls, children that fall victims or exploited by older persons. And that is becoming very prevalent in our society. And therefore, my presentation starts off with the hard facts. This is a growing problem. I'm going to cite an example to you. We had a case of a child or young girl that fell pregnant by an educator. And the mother, when we asked that she supports a child, because we now have a young girl who's pregnant, and we need to lay a criminal charge because it's a criminal offense, the mother very directly asked the social worker, will you provide my home with food? Will you be able to give us all what we need during the month, a food parcel, and make sure that my family has food? Will your social worker do that? Now, here is a problem that we are faced with on an ongoing basis where we have such cases not being reported. So statutory rape is actually a skewed picture in this country as a result of this particular example that I've just cited. I'm not going to go into the details of what sexual offences is all about, but you can have access to the presentation in this regard. Let me go into what my presentation is set to outline, which is how does the Department of Social Development support and render psychosocial support services to child and teenage pregnant learners. The Children's Act says any child that has been found to be pregnant, we are obligated to report on it. So what we are expected to do is mandatory reporting from a social worker's perspective, from a social worker's perspective, from a doctor's perspective, from a nurse's perspective, a midwife, an occupational therapist, a community member. We all have a responsibility to report on teenage pregnancy. As a Department of Social Development, this is where our responsibility comes in. Our services are twofold. We render non-statutory services, and I'm going to explain that, and we render statutory services. What is non-statutory services? It means that that particular child doesn't go through the child protection system. That child and that matter doesn't appear before a children's court. So we render non-statutory services. Pardon me, colleagues, I'm trying to be as detailed as possible for our young audience. Now, what kind of services do we render? We render sexual abuse awareness programs, and that comes in the form of life skills program, child trafficking, online safety, child exploitation, teenage pregnancy, bullying, and grooming. So what we do is we make our young people aware that these are matters you must be aware of. How do you take this information through these awareness programs and make more informed choices, decisions that are informed by this information that we've shared with you? Now we are finding our young people that are pregnant. How do we support as social development? We have teen support interventions that are rendered through the school social work program. So learners are identified, the social worker will do a safety risk assessment and will then see how best to support the learner from a social work perspective. But the school, and you'll hear from our colleagues that will come on later, how do they support the learners from an education point of view? How does health come in and support the learner from a health point of view? But we know that learners do not exist in isolation. We exist within a system, we exist in a family, we exist in a community. Therefore, the program of the department also looks at how do we support the family? And sometimes lots of the learners are absolutely fearful of going home and disclosing this information to their parents and their family, shame. And then we see there's a spike in the number of suicides because we don't have opportunities for our learners to be supported when they are disclosing such information to their families. So the social workers also render family support services, teen parenting programs, because you find that lots of our learners would choose to keep the babies, would need parenting program, but not just for the mother or this young mother, but also the boy child that was part of the process. And in most and often, we find that the boy child is actually sidelined through the entire process. And that is an important part of taking responsibility as teenagers. So the social workers facilitate these kind of support programs with both the boy as well as the girl child. Social behavior change program is an important program within the Department of Social Development. How do we empower our young people so they are able to make informed choices? Or if you are involved in maybe reckless sexual behavior, how do you then acquire this information so you are able to say this is reckless behavior, it's going to lead me into trouble, this is the consequences of it, and how do I then change my behavior and become more responsible in the way I'm managing myself. Family preservation programs, we find that most often parents don't know how to deal with this responsibility or the fact that their teenager is now going to be a young mother. So social workers will go in and try and do family preservation programs. How best can we support you as well as your the young mother, and link you up with resources so that you are able to adjust and adapt and not have this young person abandoned by their families. We also found that our young people need to or engage in certain behaviors because of there being a lack of other activities in the communities to keep them responsibly occupied. We have a number of programs that look at, and one of it is our Masupatila program, where we've partnered with Scouts SA in a very, very accelerated way so that we are able to get Scouts groups into areas. And these Scouts groups deter our young people from going into irresponsible behaviors by redirecting them to, I'm not sure what has happened to the slide, but I'll move along because of time. In the Department of Social Development, we have what is called our school social work program. The school social work program looks at our social workers entering schools and rendering all these programs that I just mentioned within the school. But here's the challenge. We don't have a social worker for all 2,000 schools in the Gauteng province. So it means that a social worker is having 1:47 schools. That is practically not possible to go to every school to respond. So what we've done is we've put a plan in place with the Department of Education where we will target all the high-risk schools. But I can tell you more and daily that high-risk schools list is increasing. So the Department of Education has then put in additional resources. So we've now partnered with Lifeline, Childline, Teddy Bear Foundation, who is big on driving the teen pregnancy agenda in terms of psychosocial support interventions within our school environment. Now, largely linked to the children's program, we have what is called the HIV/AIDS program. Now, again, we've asked our HIV/AIDS policy developers and program managers to infuse in their programs also around teenage pregnancy. So there's also the consequences of engaging in reckless behavior, and the HIV/AIDS program is also rendering support to our young learners within the school environment. I spoke quite extensively about families. Families are core in terms of supporting teenagers that find themselves pregnant. And that is very important. Like I said to you, teenagers exist within a system, and that system needs to hold together. So we have the parenting programs, we have the teen parenting programs, because you find that our young people are extremely smart these days. They want to take responsibility for the consequences. So I'm now a young mother and I need to parent this child. What do I do? How do I do it? And they have access to social media and various platforms. But as social workers, we also provide teen parenting support programs for the mother as well as the boy child who's taken responsibility. We also look at how do we foster resilient families, because you find that you have a parent who has also been a teen mother. And then you are trying to now work with a mother who's having a teen daughter who's also a mother. So that cycle needs to be broken at some point. So the social workers look at how do you build resilient families. So also providing support to the mothers who are also teen mothers. So that's a very, very complex issues that we're finding our families being faced with. And you find that more often that mother also does not know how to parent. They don't know how to manage uncontrollable behaviors. So they rather pretend that the problem does not exist. Just trying to catch up on the slides. All right. The department also has its support programs or interventions in its victim empowerment program. We also find social crime prevention, where we run a lot of teen pregnancy programs within the social crime prevention program within the department. Even we're finding a lot of our substance users that find themselves pregnant as a result of not being able to be informed choices, being intoxicated, which then obviously they are not able to make effective decisions. So in all of these programs, we're finding teenage pregnancy is a common thread, and we are responding with various programs. Even if it's a substance abuse program, we respond to a teen mother. The statutory services. Now, this is the hard part. This is when we find our teens, our child pregnant learners that need to be removed from their home circumstances, because that home circumstances is highly dysfunctional, that led to this child not getting the relevant support, and then we need to remove. That's what we call statutory services, where we then take the matter before the Children's Court and we remove children based on the Children's Act 38 of 2005. I've listed what are some of the instances where we remove children from their home circumstances. Abuse is one of them. Violence, neglect, exploitation, child abuse is very prevalent in our communities, and children are removed on those reasons. Children that have been abandoned, where parents don't want to have anything to do with a young learner who's pregnant and they are abandoned. So the department then has to look at removing those children from those circumstances. You find our young persons living or working on the streets just to survive. Uncontrollable behavior, where mom raises her hand and says, I can't deal with this. Department intervene, remove, I don't want to have anything to do with the children. So all of these children then enter the child protection system. I'm not going to go into too much detail here. Once a child who has no support, and I've listed all the reasons why they get removed, they are then placed in temporary safe care placements. They are removed, a court order is issued, and that child will remain in alternative care placement until we are able to find the family that wishes to take the child, or child is placed in a child and youth care center. And in most instances, the relevant support, psychosocial support, is rendered to that child. Some statistical data from our school social work program. Just for the first quarter, which leaves us with April, May, June of this year, we've ran 31 prevention and awareness programs on teenage pregnancy. We then have a specialized program to children between the ages of 10 and 14, which we classify as child pregnancies. We have parenting and family preservation programs. We've done about 20. And then there's the whole lot of prevention, awareness, and early intervention programs to our young people, which then amounts to 58 programs. The Department of Social Development cannot do this alone. And therefore, we partner with designated child protection organizations. And I want to pause here. These designated child protection organizations are like your child welfares, your FAMSAs, that are within the communities that are expected to support the department in going into schools and rendering psychosocial support services. The Department of Social Development, like I said, we also have, and I didn't mention this on my presentation, but let me talk to it. We also have 141 child and youth care centers. These are centers where children are removed from their home circumstances because it's not conducive. They're found in need of care by the courts, and they are taken into child and youth care centers. And I must say, once a child is placed in a child and youth care center, then we find that they are pregnant, and we need to provide the necessary support and programs to this child who was found to be pregnant in a child and youth care center. And there's more and more statistics that are coming out from our 141 child and youth care centers. The department's budget is a lot of money, and you've seen it on the screen now. But of that, just above 27% goes to child protection programs in the department. So the lion's share goes to children's services. What do we do? What are our best practices? So we're continuously looking at school-based awareness programs. We have community of practice. What does this mean? It means when we look at the high-risk schools that we have, there's certain schools that we zoom into, and we do a multidisciplinary teams that go into those schools and then render intensive psychosocial support services. But those are far and few because of the fact of resource constraints. The education and awareness programs that we render it collaboratively with our NPOs that we fund. I spoke about those 87 child protection organizations. So it's not just the Department of Social Development that goes in. So if you don't see the department, it doesn't mean services are not being rendered in that school. It means it's rendered by our partners whom we fund to render child protection services. We also have our victim empowerment, which is our VEP program, and our GBV program that also renders services to children and teenagers that find themselves to be pregnant. But a very important element that I want to stress on is you cannot render services to just the teenager. You've got to include the boy child, and you've got to include the support system around that the children. In my concluding remarks, I think it's important that we do have a memorandum of understanding with the Department of Education. So for instance, just say if there's a school where there is a spike in teenage pregnancies, the department will be called upon through the Department of Education that we come in and we render prevention awareness programs, group work, support groups, and then delve into those teenagers that may require additional support over and above all of the prevention and awareness. So then it's the individual counseling, the therapeutic intervention, crisis intervention, family preservation services. So that is in place within our school environments. But more importantly, when you look at teenage pregnancy, it's also telling us about a broader social problem we are finding ourselves in. So I spoke about young people being smart and savvy, having access to social media. But it's also important that our young people need guidance, not just within a school environment where educators will empower, social workers will intervene. We do all these awareness programs, but also empowering parents to better respond to their children. And those parenting programs is also a shift that the department is now doing. How do we empower parents to play active roles in supporting their children in terms of how do you manage social media? How do you manage relationships? Better decision making if you are in a relationship, in terms of how do you look at the best choices in terms of contraceptives. Abstinence, we even spoke about it as social workers. We say we can't be promoting abstinence when children are curious and they want to find out and then they find themselves pregnant. So we need to look at balancing the programs, reviewing our programs consistently and constantly, so it's more responsive to the young person. I think in terms of crisis intervention, those services are there. The Department of Education, and I'm not going to speak on behalf of the Department of Education, but I know they've realized there's a problem, and therefore they've now strengthened the psychosocial support services by bringing in more role players from the NGO sector to support in the various schools. I think we're finding also, largely when we look at the Department of Health, they have the integrated school health program where reproductive health is also being spoken about. Again, these three departments, which is education, the Department of Health, and the Department of Education, need to work in collaboration when we respond to these various schools. I note that SAPS is also on the program, and that looks at the child protection elements, they look at the criminal elements, they look at law enforcement when it comes to children. I think that brings me to the end of my presentation, but I just want to pause here to say, when we as the Department of Social Development respond to children out there in communities, our young people are faced with many, many social issues. The landscape in this province and across the country is changing so rapidly, where we're finding that our young people are increasingly and vulnerable to exploitation. And this is through social media, where we're finding that lots of our young persons are vulnerable to. And as we strengthen our programs, it's not just about strengthening the psychosocial support to the child, it also means strengthening the psychosocial support services to the family, as well as making communities more aware that when they do observe any form of exploitation of our children, they have a legal responsibility to report on it through the provisions of the Children's Act. I want to pause there and thank you very much.
Thank you to Yvonne about the presentation, which I think, in my view, she's just presented hard truths, nothing else but hard truths. And I think hard truths that are really shouldered by the Children's Act insofar as protection and provisions for children. And I think the presentation is really asking hard questions. Earlier on, Commissioner Namatayeni spoke about the principle of choice. And now Yvonne is actually bringing in another spin insofar as where are the families? Because education, if I understood you, you are saying education has been done, children, and we cannot say it's been done enough, but there is a very comforting indicator that points to the fact that education is being done and children are being provided with knowledge. But then within this community of practice, understanding that there is SAPS, there is Department of Basic Education, there is Social Development and Health, where are the parents within this, value chain of ensuring that care is provisioned and that care is actually provided for? Where are the parents, and who is really ensuring that parents are educated and held accountable? Because in the main, Yvonne is saying this is statutory rape. There is no other term for it. This is statutory rape. We are all agreeing. And these are the matters that are happening back at home. So where are the caregivers? Where are the legal guardians? Where are the parents? This is a transitioning conversation, which I want to believe that it is actually taking us somewhere. And at the end of the day, we should be able to come out with outcomes that must redirect us if there is a need to do so. Colleagues, we have come towards a need to take a body break. so that we can catch up with ourselves. And I have been informed that bathrooms are on the far left, others are just found within the foyer where we actually took our tea this morning. They're not unisex, but you're more than welcome to use any. And therefore, I will then be asking us to just take a break. And the time now, we managed to really catch up and make it within the provision time. And we then should then be taking a 10 minutes break. The time now is 11:30, and we are supposed to be back here at 12:20. Thank you very much. We may take a break. Welcome back, colleagues. Please take your seats. Please take your seats so that we can continue. It is our wish that we may finish with the conversation, and then later on we may continue with networking. I understand that this is a very robust conversation that just calls for us to continue to talk amongst ourselves. And we would also wish that we can finish up early so that we can beat the traffic. We understand that it is a Monday afternoon today, and there tends to be high traffic volumes, and we really wish to finish so that we can be kind to ourselves. As we move along, colleagues, we're gonna be bumping a little bit up the program before we go for lunch. And how we're gonna do that, we are going to then now be led by the Department of Health. The presentation is on the health sector response and adolescent sexual and reproductive health. Just following Yvonne's presentation that speaks to the community of practice models. And I really believe that the Department of Health is going to be showing us how are they dealing with this medical interventions and the provision of a reproductive care. I think I want to lean more towards your terminology, Dr. Mbokazi, insofar as providing prevention and choice principles for the adolescents. And followed by that, we're going to then take the Department of Basic Education presentation on school retention and support for pregnant learners and young mothers. And from there, we will then take a third presentation from the UNFPA alongside DDG of Women, Youth and Persons with Disabilities, DDG Shoki. I hope I have the surname correctly. And they're going to be co-presenting on the work that the department is actually doing insofar as the NSP is concerned. And after that, then we will then head towards lunch, and we are going to just trim that 1 hour, 10 minutes lunch time provision to a 45-minute lunch. And we may actually take our dessert back to the room. We're more than welcome to do so that we can still be on time. As we are moving along, colleagues, I now call upon the Department of Health to give us the presentation on the health sector responses, and may put our hands together for the colleague.
Thank you, Chairperson. Good morning, colleagues. My name is Feni Mutswane. I'm with the National Department of Health. I'll be taking you through an overview of the health sector response towards adolescent pregnancy. But as the presentation is being set up, let me just thank the opportunity to present in this forum, and also to clearly indicate that whatever we'll be presenting here is not the Department of Health's work alone, but it's a collaborative effort by all government departments, civil society, the community, and the learners themselves. So this presentation was prepared by my colleague, Ahlamalani Nenjelele, so I'll just be taking you through it. So that's the content, the purpose of the presentation, the role of the National Department of Health. I think we've seen already in terms of the trends of adolescent pregnancy, a few slides have been shared already, but we'll go through this also, the 5-year trends, as well as the Q1 for this financial year in terms of data, the provincial highlights, why adolescent pregnancy matters, a bit of a legislative and policy framework, as well as the global commitments, National Department of Health response framework, the strategic pillars, progress and achievements, the current situation, way forward, and recommendations. So the aim of the presentation mainly is to provide an overview, like I indicated, on the current status of adolescent pregnancy in South Africa, but we've heard the previous speakers who have already alluded to this. The legislative and policy framework guiding the national response, interventions implemented by the National Department of Health and partners, the progress and ongoing challenges and areas requiring strengthening the multi-sectoral collaboration. In terms of the role of the Department of Health provides leadership and governance. So at the National Department of Health, there's where policies, guidelines, and frameworks are being developed. And the department also coordinates the health sector response towards adolescent pregnancy. The other area is looking at health promotion and prevention, hereby promoting healthy behaviors and comprehensive sexuality education jointly with the Department of Basic Education, because the adolescents, mainly we find them in schools. Increase access to contraception and HIV prevention services, implement adolescent and youth-friendly health services. When it comes to clinical services, we talk to providing sexual and reproductive health services, providing antenatal, delivery, and postnatal care, preventing repeat adolescent pregnancies through postpartum family planning. We continue and look at the child protection, wherein we identify and manage pregnancies among girls aged 10 to 14 years as child protection concern, because we had already the emphasis from the colleague in DSD, this is statutory rape and it should be treated as such. Strengthen mandatory reporting and referral pathways, monitoring and accountability. We do have data collected through the district health information system. So such is monitored on a quarterly basis, shared with provinces who must now develop action plans and see all these areas where they've got increase or decreases, and see how best they can assist the communities and work jointly and collaboratively. Supporting provinces with data analysis, implementation, monitoring, and performance improvement. And when we look at the multi-sectoral coordination, I think all the stakeholders, if not all, but mainly, they are in the room. DBE, DSD, SAPS, Justice, Department of Women, municipalities, civil society, developmental partners. I know our colleagues, UNFPA, are here, as well as implementing jointly coordinated national responses. So mainly these are the data. And when we look at the data for the past 5 years, I know from the concept document, the baseline was around the 2021-22, if I'm not mistaken, but these are the trends. When you look at this, this is data for deliveries among your 10 to 14 years. So it's this is the provincial data as well as the national data. It has been said already since in the morning, when you look at the national figures here in the bottom, you can see that steady decline, you know, ranging from 2021-22, where over 3,900 10 to 14-year deliveries were recorded nationally. There's a drop. And in 2023-24, over 2,700 in 24-25 and 25-26. So there is that steady decrease. And this clearly shows the collaboration among all the sectors that I've indicated. And when you look at that in terms of the numbers, there's that decline that is visibly, and in terms of percentage also, it talks to 49.1 based on the 2020-21 data. So this is just the in-depth provincial figures. I know the numbers are fairly small, but the presentation will be shared, but it talks to the same thing, whereby the decline is just being observed. And it's still trends of deliveries among your 10 to 14 years in facilities. And when you look at your 15 to 19-year-olds, still for the 5-year period, we have seen close to 21.2% decline in terms of numbers, a drop of about or more than 28,000. You can still see there the decline year on year on the bottom. And when you look at the provincial numbers, as Dr. Mbogazi has indicated, you can see KZN there reporting high numbers with over 34,000 deliveries in a year. Even in the following year, the numbers are hovering around 28,000 and 34,000. So this is the main and biggest contributor towards deliveries among the young people. And when you look at the Eastern Cape, I just want to support what the previous speaker had said. You can see those are the high numbers, but similarly is Gauteng also, because they are recording over 20,000, and it's only in the previous financial year where just below 17,000 cases were reported. So those are the detailed trends in terms of the provinces and just in the graphic form. So now when we go to the facility deliveries among your 10 to 14 years, 15 to 19, as well as the termination of pregnancies. So these are the termination of pregnancies that are done in designated healthcare facilities, because you can appreciate that not all the health facilities conduct termination of pregnancy, because also it's not all the healthcare workers that are trained. So they opt in to actually be trained, and the facilities are accredited to actually perform the termination of pregnancy. So that's why we have these numbers. So for your 10 to 14-year-olds, these are the deliveries just for the Q1. In terms of the termination of pregnancy among the same age group, we see Gauteng having recorded the highest number. That is in the April to June. That is Q1 of 2026-27. And KZN, the deliveries were 74, the termination were 6. We're not sure if this is a true reflection or does it talk to the lack of services, because the trends also need to be monitored. And when you drill down even to the district level and sub-district, or even the healthcare facilities themselves, you will see where if this is a true reflection or is there a problem with service provision. In Northern Cape in this quarter, they reported 7 deliveries among your 10 to 14-year-olds and no termination of pregnancies. When you go to your 15 to 19-year-olds, we see KZN there with the highest number of deliveries and also topping up with termination of pregnancy. So this matches what the previous speaker has indicated. In terms of narrating the data, we have seen a total of 18,330 adolescent deliveries recorded nationally during the April to June period, with 296 being among children or adolescent aged 10 to 14 years. And among your 15 to 19-year-olds is 18,034, while the termination of pregnancy nationally over 3,388. When you look at the 10 to 14-year-olds, 115 were performed and over 3,200 among your 15 to 19-year-olds. When you now zoom into the provincial highlights, as already indicated, KZN recorded the highest number of adolescent deliveries, with Eastern Cape following with that percentage of 17.6. We're seeing Gauteng this time around recording the lowest rate of 9.4. The vast majority of adolescent pregnancies occurs among your 15 to 19-year-old. But also we still see a whole lot of deliveries among your 10 to 14-year-olds as well. Yes, I think I've indicated. When we continue with this, while most adolescent pregnancies occur among your adolescent age 15 to 19-year-olds, that is a total of 98.4% in terms of the numbers, but we still see or saw or recorded 296 pregnancies among your 10 to 14-year-olds. So meaning that every pregnancy around in the 10 to 14-year-old is regarded as a child protection concern, requiring investigation for possible sexual abuse, exploitation, statutory rape, with appropriate referral through child protection. And I must indicate that we do hold quarterly seminars with the support of Department of Social Development through the Departmental Knowledge Hub, where the mandatory reporting of statutory rape is actually emphasized. The healthcare workers are also taken through how to complete Form 22 and reporting. So we are working jointly with the Department of Social Development. So we now look at why adolescent pregnancy matters. For the Department of Health, we know that, first of all, children are not supposed to be pregnant. So adolescent pregnancy is associated with high numbers of maternal morbidity and mortality. We see neonatal complications among this age group of your 10 to 19-year-olds. We also see school interruptions and dropout. And what also have been observed is that there is a repeat in adolescent pregnancies. When we go out to the healthcare facilities and do data quality audits and even look at the termination of pregnancy, you see an adolescent age 17 years coming to terminate for the second time or for the third time. So that's a reality. What is happening? The services are there. Others might not know about them, but those who know them, they do use or tend to, I can't say abuse, but they access them. HIV and sexually transmitted infections also is a concern among this age group. especially around your 15 to 19 or even to 24-year-olds, the gender-based violence, the intergenerational disadvantage and poverty that's recurring, you know, because they do give birth in the poor families where there's no adequate food. We see a series of malnutrition, you know, all those health challenges, they are just playing themselves all over again. So in terms of Q1 data, this confirms that adolescent pregnancy remains a significant public health, social and child protection challenge. In response, the Department of Health is implementing a comprehensive policy-driven and multi-sectoral package of interventions aligned to the national legislation and strategic framework, as I indicated. So these are some of the legislative and policy frameworks that guides our interventions or health responses. We know everything is grounded from the Constitution of South Africa, the National Health Act, the Children's Act 38 of 2005, where we enforce a mandatory reporting of cases of child abuse and or neglect, the Criminal Law, Sexual Offences and Related Matters Amendment Act. When we look into the national policies, we've got the 2017 policy on the national adolescent and youth health. I can say now this policy is what informed the age disaggregated data of 10 to 14 to 15 to 19, because prior to 2017, we were just reporting adolescent or teenage pregnancies for under 20 years. But after the policy, with the indicators and the data, we saw that improvement in reporting and data management. Of course, the integrated school health policy, colleague from DSD has spoken about this, where the three departments are working together. The 2023 to 2028 National Strategic Plan, clinical guidelines, and the GBV and Femicide National Strategic Plan. But of course, we know that South Africa is we are also committed, or the UN, do you want to say now? We are subscribed to UN, and we also need to look at the global policies and strategies, whereby in terms of the global commitments, the SDGs, number 3 for good health and well-being, number 4 for quality education and gender equality, which is your SDG number 5. So this is just to unpack the global commitments in terms of the SDG numbers and the target. When you look at your good health and well-being, which is the 3.7, the relevance to the adolescent pregnancy is that it provides universal access to sexual and reproductive health services, and adolescent birth rate 10 to 14 and 15 to 19 are being monitored as the indicated 3.7.2. When you look at the quality education, keeping adolescents, especially girls, in schools, comprehensive sexuality education and life skills, and in terms of the gender equality, eliminating harmful practices which affect girls, and universal access to sexual and reproductive health and rights. The health response framework, this talks to the 5 strategic pillars, of which we're looking at preventing adolescent pregnancy, providing comprehensive adolescent sexual and reproductive health services, protecting the vulnerable children and adolescents, supporting pregnant and parenting adolescent, strengthening multi-sectoral coordination, monitoring, and accountability. Of course, these are guided, are the policies guided by the legislative frameworks. The department has implemented interventions across the continuum of prevention, care, and service delivery, child protection, and multi-sectoral collaboration. We also have pillar 1 and 2 that talks to prevention interventions, which includes your AYFS, or the adolescent and youth friendly services, These are now incorporated in the ideal clinic. So for every facility that's being assessed, there is a component of adolescent and youth-friendly services. And within the department, when we look at the data on a quarterly basis, we can see that over 2 million young people aged 10 to 19 years do access the health facilities. However, we're still having a challenge in terms of aggregating the services that they have accessed. But as we can monitor and check on the termination of pregnancies and deliveries. However, we cannot measure in terms of contraceptives how many have been accessed because we do not have that specific indicator that's age disaggregated. We also have youth zones in primary healthcare facilities which are dedicated clinic times that looks at the learner timetable in terms of accessing services after schools or even over the weekend. The sexual and reproductive health education. We also have the specific training for healthcare workers that is aligned with the CSE that they need to give age-appropriate information and that the learners themselves, they do access these services through the curriculum. The comprehensive contraceptive services, HTS services, the sexual transmitted infection screening and treatment also still fall under Pillar 1 and 2. The PrEP, and now we also have the injectable one, the lenacapavir, the community outreach, parent and caregiver engagement, peer education, and health promotion campaigns. When we look at Pillar 2, which is the crux of the service provision of the Department of Health, that entails contraceptive counseling and service provision, dual protection, emergency contraception, long-acting reversal contraception, as well as HTS, pregnancy testing, antenatal referral, postnatal contraception, and cervical cancer prevention, and of course the human papilloma virus vaccination that is given in schools for girls aged 9 years and above. And now since 2024, this program has been expanded to girls in private and independent schools. When you look at Pillar 3 and 4, which talks to child protection and care and support, for child protection, I've already indicated the mandatory reporting through completion of Form 22, strengthening referral pathways, psychosocial support, that's also being started within the department, but then referred to the DSD for continuity as this is their expertise and through the school social work. But what I can say is that we only know from the school health program that the school social work services are mainly in Gauteng and in Western Cape. So these are the areas that still need to be strengthened and expanded. The collaboration with DSD, with SAPS, multi-sectoral case management, and strengthening reporting system for child abuse and neglect. When you look at the care and support, we talk to early antenatal bookings whereby all the screening services need to be conducted, quality antenatal care and referral, PMTCT or VTP, vertical transmission prevention, nutritional support, mental health screening, birth preparedness, postpartum contraception, prevention of repeated pregnancy, as well as in this regard, linkages back to education. This just talks to all the stakeholders. I think we've already alluded to is just the sectors as well as their role. I'll skip that. Now, when we look at the progress and achievement that you have made thus far, is that we do have the youth zones established across the provinces. And there's this continued implementation of adolescent and youth-friendly health services, increased access to contraception, expansion of HIV prevention services and improved collaboration between sectors. We strengthening the school health services because that's where the on-site health services are provided with learners being in schools, and strengthening adolescent health data systems and management, developing digital or automated mandatory reporting system. So this is the project that we are embarking on so that we can even track all those cases that are reported to DSD if we do have this automated mandatory reporting tool, which should include data elements and indicators to strengthen monitoring of child abuse and or neglect. When we look at the current challenges, we still see young people indulging in early sexual debut. And that's where we need, that self-discipline, self-information, the family and the community, intervention and engagement, the gender inequalities, sexual violence and transactional sex, poverty, school dropout, unequal access to adolescent and youth-friendly services, which are not spread evenly across the country, fragmented reporting system, and repeat adolescent pregnancies. When we come to the way forward, the implementation of the National Adolescent and Youth Health Policy need to continue, scaling up of adolescent and youth-friendly services, comprehensive contraceptive access, the use of routine data for action, strengthening implementation of mandatory reporting and automating Form 22, intersectoral accountability, community mobilization, and adolescent participation. This is the last slide that talks to the recommendation that we need to strengthen the intersectoral coordination national or across all levels of care, prioritization of high burden district using routine data, and strengthening implementation of child protection protocols for pregnancies among girls aged 10 to 14, enhancing community mobilization involving parents, caregivers, traditional healers, and faith-based organizations, expansion of AYFS, and strengthening data sharing, monitoring, and accountability across the sector. So this is just a call for action that we need to continue with coordinated implementation across all sectors, integrated planning in hotspot districts, strengthening protection of children, data-driven decision-making, accountability, community-wide prevention efforts involving families, schools, communities, and young people. I thank you.
Thank you very much to Ms. Mochwane. And I am sure that we can, again, just give strength to the presentation. I know that this presentation is really giving a grim picture of what we may not have wanted to hear. However, these are the realities that have been put out by the National Department of Health, a picture that really paints the country view. I think from a monitoring and evaluation point of view, it's giving a picture of what is it that the Department of Health is dealing with and where are they coming in terms of the clinical and education support and provisions thereof to try and to eradicate the scourge of teenage pregnancy. I see the trends that they are not looking good at all. We should be seeing a zero picture when it comes to the aspects of adolescent and teenage and child pregnancies thereof. And I see the intergenerational health, social, and health impact that actually this puts towards children. And I do want to believe that if we were to immediately bring forth the justice cluster, we may be able to balance this conversation so well. I know that they are in the program, because what we want to see is, are these 18,000 plus numbers of birth rates translating to what gets into the books of SAPS and NPA? And what does this mean insofar as the prosecution's point of view? Where are we going as a country? Is there something that we are missing? Is there a gap within, these roles? What is it that we are seeing? And I hope that the cluster is going to give us that presentation as they come forward. Thank you so much to the Department of Health for this high-level presentation. Colleagues, these presentations are going to be put up into the website under the hashtag Teen Pregnancy Imbizo, so that we can always draw some data out of them as and when we need to make a point of reference. And as we then move along, colleagues, I'm gonna then be asking the Department of Basic Education. I'm told that Salome Sigida will be giving us the presentation on the aspects of education, school retention, and support for pregnant learners and young mothers. As she comes forward, Selector, you may give us an item. Thank you.
Good afternoon, colleagues. And good afternoon to my learners. How are you? Yes, we are from the Department of Basic Education, so they are my learners. Yes, so let's give them a round of applause for being here. So just to say, colleagues, please excuse my voice. I'm a bit fluish and I might be coughing during the presentation. Do I control it myself? Okay. As indicated, colleagues, I'm Salome Sigida, Director Health Promotion from the Department of Basic Education. So I'll be presenting on the comprehensive approaches to preventing and addressing early and unintended pregnancies. So our starting point, colleagues, is that teenage pregnancy is not only an education or a health issue, it is influenced by interconnectedness, social, health, economic protection, and gender-related factors. I think these issues have already been alluded by the presentations before me from Department of Health and also from the Department of Social Development. Therefore, our response must be equally comprehensive, bringing together prevention, education, health services, psychosocial support, child protection, and continuity of learning. So colleagues, this slide provides the context for why an integrated response is important and it's necessary. So the figures presented here demonstrate that learner pregnancy does not occur in isolation. Young people are simultaneously exposed to risk relating to HIV and sexual violence. The presentation from the Department of Health showed us that there are children, they are not teenagers, 10 to 14, that are falling pregnant. Colleagues, that is not teenage pregnancy. That is sexual assault. So we emphasize from the Department of Basic Education that if a learner is pregnant, if a child is pregnant in primary school, 10 to 14, that is statutory rape. Form 22 must be completed and that should be reported. So this slide also shows that HIV prevalence amongst AGYW is higher in girls than in boys. And it also highlights concerns around sexual abuse and violence, as well as the high proportion of teenage pregnancies and unintended pregnancies, which in most cases then relates to school dropouts. So colleagues, so the Department of Basic Education has established a comprehensive policy and education sector response. So we are known for our beautiful policies and, frameworks, but we are criticized for implementation. So we have the policy on the prevention and management of learner pregnancy in schools. However, that policy cannot be viewed in isolation. So we have this policies and frameworks. We have the integrated school health policy that was mentioned by Department of Health. We have the protocol for the management and reporting of sexual abuse and harassment in schools, and all other policies that you can see, colleagues. So colleagues, we have the policy on the prevention and management of learner pregnancy in schools. I believe that colleagues know about this policy. You know about the policy? Yes, great. So the policy has two fundamental objectives. So the first objective is prevention. Reducing learner pregnancy through quality CSE and improved access to youth-friendly SRH services. And when I came here, I think it was Doc here, that our learners have information. So previously we were criticized that, learners don't have information about SRHR, about the dangers of teenage pregnancy and all that. But through comprehensive sexuality education, we can say, and life, which is implemented through life skills and life orientation, we can say as the Department of Basic Education that our learners do have correct information. So the second one is protection of the right of education, ensuring that a learner who becomes pregnant is not excluded from education or because of pregnancy or childbirth, which also ensures that after pregnancy, a learner must go back to school and complete their education. So our measure of success should not only be fewer learner pregnancy, but also whether pregnant and parenting learners remain in school, return after childbirth, and ultimately complete their education. Colleagues, I think we know now that education remains one of the most protective factor, and we also saw this during COVID pandemic, where majority of our learners fell pregnant because they were not going to school. So the LPPM, we call it the LPPM policy, which is the policy on the prevention and management of learner pregnancy. It has 5 policy provisions. So, so we need an enabling environment where learners are safe and protected from stigma and discrimination. And the second one is prevention, as I've indicated, colleagues, which requires access to SRH information and services. Thank you so much. And the third one is care, counseling, and support, which was presented by DSD, which they've indicated the work that they are doing around this. The fourth one is impact mitigation. Pregnancy should not be and automatically result in educational exclusion or permanent dropout. Just because a learner is pregnant doesn't mean that they must be excluded from education or should not return to school after childbirth. And we need suitable structures, colleagues, from national to school level for implementation, monitoring, and reporting of the policy. So in terms of policy implementation, these colleagues have been indicated by the colleagues that have been presenting here that, the policy is not implemented in isolation. So with education, we have the integration through the curriculum, as I've indicated, through life skills and life orientation. And we are strengthening the implementation of CSE through LO and LS, and also the co-curricular support, HIV/AIDS, life skills, and the integrated school health programs. And then we have linkage to services, which was presented on by the Department of Health. So we have the CS policy, which is screening, identification, and assessment support. We have our school-based support teams responsible for referrals, and we also have learner support agents that are placed in high priority schools. So we do get data from the Department of Health, and with that data, we then see which schools really need our our support, where those schools are then regarded as high priority schools. We also, in terms of collaboration, we have ISHP programs where we collaborate with Department of Health and Department of Social Development, and also national programs of action on teenage pregnancy. And we also work with, Department of Women on the national strategy that they are currently working on with the UNFPA. And with service provision, we still rely on Department of Health and some of the partners that we work with in terms of providing services for our learners. So in terms of the implementation of CSE, when CSE was introduced, there was a lot of pushbacks from parents, from religious leaders, from traditional leaders, with a lot of myths. One of the myths was that we are teaching sex education, we are teaching learners how to have sex. Is it true, my learners? It's not true. It's not true. I'm glad you are here. You can, give us exactly what you are getting in the classroom. The purpose of CSE is to empower our learners so that they are able to identify and report sexual abuse, prevent HIV infections, and those who are born with HIV to stay on treatment, prevent learner pregnancy, prevent bullying and negative peer pressure, know where to get help when needed, stay in school until they complete grade 12. So that's the ultimate purpose of CSC, not the other things that you have been hearing about it. 5 minutes, okay, sorry, I'm almost done. So the lesson learned from the policy development. So one of the most important development in strengthening the implementation of the LPPM policy is the development of and the legislative process in the development of regulations. So as the Department of Basic Education, we were mandated to develop the BELA regulations on the management of learner pregnancy, and those regulations are in development. When approved, will be shared with everyone. Thank you so much. Short and sweet. My apologies for the cough.
I think we can really put our hands together. For the Department of Basic Education presentation that is really giving us a clear picture of what is provisioned from a policy point of view as the national department, understanding that the implementation most definitely is carried by districts and also by the schools themselves. But what we are actually seeing here is a policy provision which we may, of course, really agree that it is there, and as to how much of it is really being implemented. I think the shortcomings, we are always known that they are there, but then what is good, and also as a starting point, is to see that there is a policy provision, and if there is any issue insofar as the aspect of reporting Form 22 that is not happening, we are going to be able to see that if this is indeed really happening, and if there are gaps, and I want to believe that the justice cluster should be able to really balance out these three departmental presentations and give us a picture of what is it that we may not, what is it that is actually lurking from a reporting and also from an implementation point of view. Colleagues, these presentations, as I indicated earlier, they are going to be put out onto our website so that we can have access onto them, make a point of reference where it is actually needed. And as we move along, colleagues, I do wish to really acknowledge the Johannesburg Metro Police Department amongst us today. As we understand that in Gauteng, or rather in Johannesburg, they are the eyes and ears of society, especially from a social crime prevention point of view. They see what we may not be seeing from a policing and also from an awareness and prevention point of view. I am tempted, in fact, I just want to do this. Allow me, Dr. Oveni, to just put a spin onto the program just for a minute. I know that we have the Glen Vista High in the room. Clock it, Glen Vista. And I just want to give the learners an opportunity, just one learner for each department: basic education, health and social development. Just 3 learners. If we were to give you an opportunity to give an advice to each of these departments insofar as the issue of teenage pregnancy and learner pregnancy, what would be that advice? This conversation needs not to leave out this greater advisory that could be coming from those whom we've actually invited. So I'm just going to ask the technical desk to just take around the microphone to just 3 learners. One, we start with basic education, the most recent presentation, and then we then move to social development, and we go back to health. What would be that one advice you were to give into these departments so that if they go back to their respective departments, they may go back with some different perspectives altogether? So you may start by acknowledging the good thing that they are doing and then move to the advice. What is it that they may do? Thank you.
Good afternoon, everybody. My name is Reavetso Bothelotau. I am a learner at Glen Vista High School, and I also represent the Johannesburg Student Council today, wearing my blazer as the junior speaker of the city of Johannesburg. And then I just want to firstly acknowledge the good work that is being done by the Department of Basic Education with regards to educating us about our bodies and making it normal that conversations such as these are not stigmatized, and that it becomes an open space, especially within places like school, where you are able to approach your teachers or approach your friends and other learners with conversations as serious as these, because we do understand that these are conversations that we would otherwise probably not have had they not been normalized. And then my just 2 cents of advice would then be to also recognize that it is then also the contribution of the fact that the boy child is able to just so crassly and carelessly sort of speak about the female learner and then not receive much repercussion with regards to it. It's in the daily language that we hear, like, I want to crack, this, that, and the third, where we let that slide, and then that develops into something much bigger later on when we could have stopped it right there. And this is not to say that there aren't people doing their level best to sort of prevent such a thing, but it also becomes then the chat of the idea, rather, that we could do better with regards to that. And that's it. Thank you.
Good morning to all in the house. My name is Mohadi Patience Sabatoma, all the way from Vista High School. And my advice is we acknowledge the awareness that you guys are raising, the good work that you guys are raising. But another thing is you guys can also implement a line whereby we have lines where like 10,111, for example, because not everyone, for example, in KZN, we were told that there's 75% of rural. So we can implement a line whereby you can call anywhere, anytime for help and advice. And that could help a lot of people because not everyone has access to internet, apps, and you guys' social media platforms for help. And that's what I was saying. Thank you.
That's it. And I think this really sums it all. They are saying, yes, they are acknowledging all the good safety nets that are being put out. And however, mostly to the teachers, educators, and every care worker who's in the room, something profound has just been said to say, for the boy child, stop it right there. When there is an indicator that's being set, because ignoring such utterances could lead to a long-term incidents that we may not want to deal with. And when we do that, I do want to believe, Dr. Mbogazi said, we must do things with care. We may want to put a repercussion in trying to stop whatever it is that is being said or done. But again, the repercussion or the action, it has to be corrective more than it being punishable. So I think these are the ideas that are coming from the learners, acknowledging the good work that is being done. And secondly, another view, it says, why not put out a helpline? And I would imagine that this helpline is supposed to be free so that even a learner in KwaZulu-Natal, deeper rural, Eastern Cape, Limpopo, because I see these are the provinces that are coming, highly, and Gauteng, that they may be able to really ring the bell, because the issue could be right here at home and I may not be able to go to the police because I may be police even right here at home. But the guarantee is actually known that children do have access to technology one way or the other. Therefore, the least that the country could do is to provide a free or helpline wherein children may be able to access so that they can ring the bell when there is a problem at home. And lastly, another advisory that I gotten from one of the teenagers, one was actually saying, would it be a difficult ask, I want to use the language, ask to actually put or ask Department of Health to make rounds into the schools so that those who need to access contraceptives, that they may actually get them from school? Because here's the trick, others use school transport to commute to school, and going to a clinic may mean that the same child must ask for a bus or a taxi fare from the parent. And here is where the trick comes in. It is when I need to disclose to the parent or to the guardian that I need to go to the clinic because I need to go and access a contraceptive. and we understand sometimes how the response from the parents would be like. So now students are saying, yes, of course, the department is already burdened with all these other requirements that are really necessary, but maybe this is something that, government may consider to actually allocate healthcare workers to go make rounds to those schools so that this could still be a private matter between myself and the healthcare worker without having to disclose to my parents that actually I'm on contraceptives now, because not all parents are accommodative and that flexible to understand that their children are on prevention. So this is a further advisory, Department of Basic Education and Department of Health. There can always be a provision, in my view, that can always be negotiated in the same manner that there are rounds of healthcare workers providing the HPV, vaccination to schools, that this may also be something that could be necessary so that there could be a promotion of that access. With that said, colleagues, we are going to then move along, asking Sispuleng to just maybe speak with the kitchen so that they may actually push our lunch, starting time a little bit with 30 minutes, because now we just need to bring forward the UNFPA alongside the Department of Women to actually give us the presentation on the technical support on the development of learner pregnancy, which is more on the national strategy. With that said, let's put our hands together, colleagues, for Department of Women and the UNFPA. Thank you.
Good afternoon. Thank you. It's not post-lunch. I was just checking whether, Mr. Machoba, were you able to send the presentation through? Got it here? Here it is. Assist me. Let me start in the meantime. The Department of Women, Youth and Persons with Disabilities is not an implementing department. Our programmatic thrust comprises almost 4 key areas of intervention, one of them being mainstreaming. And we make it a point that we analyze the annual performance plans of all the government departments in ensuring that the issues that are being discussed here are actually mainstreamed into their performance plans and that they are being resourced adequately. That part is very critical. Annually, we don't skip that area. We stop everything. We assign the APPs, annual performance plans of the departments. We analyze them. We wear that lens. We make comments. What they do with it is something else, but we do that part. We also ensure that we deal with issues of policy development. That is why we have a national strategic plan on gender-based violence and femicide. We develop frameworks, your sanitary dignity framework and all of that. But our job is to ensure coordination, monitoring and evaluation, put institutional mechanisms in place. I'm buying time whilst they're working on the presentation. Put institutional mechanisms in place to ensure effective coordination. But with that, we then report to the president because we are a department that has the other leg in the presidency. Ideally, we are known as a Department of Women, Youth and Persons with Disabilities in the presidency because our minister is a minister who is located directly in the presidency. But at the end of the day, when we do that, that's where we actually highlight areas of development, much as we acknowledge the strides that departments have made, and we make recommendations. When the president has his one-on-one sessions with those relevant ministers, those issues then will be picked up. But I have to indicate that In everything that we are doing, our resources are somehow constrained. Both your human and financial capacity is not fit for purpose. That I have to say. You can go through our annual reports and read and check for yourself. The kind of structure that we are having. Let me give an example. You may be called a branch. NEDOC. Do you have a sense of what a branch consists of? It will have chief directors. I'm not saying chief director. Chief directors, 2 to 3. It will have directors underneath, 2 to 3 max. If it's more, you are lucky as a department. It will have deputy directors. It will have assistant directors. Then it will have your support staff. Guess what is the case in our department? I'm the branch head, DDG level, 1 chief director, 1 director, 1 deputy director, 1 assistant director. And we are expected to execute the task across all spheres of government, where possible, civil society, including private sector. That on its own is a limitation. But nonetheless, we use our power to convene. We then pull the relevant government departments because we've noted that with that limitation, there's more that we can do by bringing government departments together. It is for that reason that we have been assigned the responsibility to lead on the implementation of the issue around teenage pregnancy. It is in our medium-term development plan. Access the website of DPME. One of the priorities relates to us dealing with the whole issue of reducing teenage pregnancy. It gives a target, it gives a timeline and all of that. On that basis, by virtue of being the lead department, we then took responsibility to coordinate the whole of government and make sure that we develop that NSP. But because of the reasons I alluded to earlier on, we reached out to a very good partner, UNFPA. And they never said no to us. They opened their doors. We worked out a clear MOUs and all of that. And as such, we are moving. I won't say partners in crime, but partners in social development work. Now, the issue of mitigation and eventual ending of adolescent pregnancy is a mandate given by Cabinet to our department, and I alluded to the MTDP process. As a result, the minister delegated the responsibility to the Deputy Minister, Steve Mapaseka-Letseke, who then convened a teenage pregnancy breakfast session that was on the 9th of July, 2025, wherein a wide range of government departments were then invited. The outcome of the breakfast session was for the decision to develop an NSP involving departments that are already constitutionally and legislatively mandated to implement interventions with requisite budget allocations, of course. And subsequent to that, we partnered with UNFPA, as I alluded to earlier on. We jointly convened an adolescent pregnancy national consultative Indaba that was on the 28th to the 29th of November, sorry for that, in order to have government, civil society organizations, non-governmental organizations, UN organizations, and others to analyze the drivers of the phenomenon and to develop a plan of action to combat the scourge. Task team was established before the Indaba, and it continues to exist post the processes of the development of the NSP. Through collaboration with UNFPA, the organization funded the appointment of a consultant to assist in drafting the NSP, and Dr. Naomi, but today we will be led by our dearest colleague, Ulenduza Ntatembata. 3 important documents that we have used, I won't allude to them. They've already been mentioned earlier on by our fellow colleagues in the interest of time. But strategic outcomes of the NSP, increased reach and impact of age-appropriate comprehensive sexuality education, and child marriage. I can indicate that the process of the child marriage bill is at parliament level, but also the process of working on the ratification of the protocol in ending violence against women and girls is also another process that is underway. We are leading that as a department working with DERCO. Increased access to and uptake of contraception among adolescents who need them. reduced unsafe termination of pregnancy and related morbidity and mortality, and improved adolescents' maternal health outcomes through increased uptake of quality maternal health care. Now, current processes on 22 Feb, the department partnered with Prof. Zozo Nene. We reached out, working with the University of Pretoria, to some of the areas, particularly we went to George, Western Cape, dealt with issues of adolescent pregnancy. On the 3rd of March, we met to give own perspective post-Indaba to develop a line of march and consider information relevant to the strategy drafting team. On the 13th of March, through a collaboration with the National Planning Commission, etc., a youth assembly was held at the DPME building in Hatfield to get the youth voice so that they give their own voice into the NSP process. Mark my words, we heard you about the line. But I'm not sure. We should explore whether we can enhance the existing GBV command center to address what we are doing, because setting up infrastructures in government doesn't happen overnight. But we need to have a bilateral engagement with DST and see whether can that functionality be included so that we tap on an existing public resource. On 31st March 2026, the department and UFP met the University of Cape Town's Gender Health and Justice Research Unit because of their interest to support the NSP process. Furthermore, on the 14th of May, an academic webinar was held in conjunction with UNFPA, National Planning Commission, and Human Science Research Commission. 30th May, we engaged with Limpopo Provincial Administration and its stakeholders on their own provincial strategy. So we are running several processes whilst we are focusing on the national strategy. On 22nd June, through collaboration with Bayer and Organon organized a private sector consultation. And on the 13th of August, we organized a consultation session with KZN, provincial administration, and stakeholder, which shall be followed by Northern Cape and Eastern Cape in the next 2 weeks of September. In the second quarter, government-wide consultation to include national, provincial, and local government institutions should be taking place. Consultation with non-governmental and civil society organizations, including youth formations, are on the radar. Organized local government through the South African Local Government Association too, and consultation with traditional leadership and governance and faith-based organization. By the 3rd and the 4th quarter, we will continue with consultation processes with government clusters. Now it's the social cluster, the justice cluster, and the economic cluster. And the 4th quarter, we will present to Cabinet Committee and to Cabinet for approval of the NSP. If it's not approved by Cabinet, then it's not a document that will carry teeth for us to be able to implement. So we've mapped out a roadmap for yourself. You have a sense of where we are heading to. Over to you, my dearest colleague. When you see them doing the work, you must know we are partners in this.
Thank you. What's our tech guy? Thank you. I'm between you and lunch, so I'll be very quick because DDG Shoki has taken some of the slides for me in terms of the way forward. My name is Tulani Mbata. I'm with United Nations Population Fund, UNFPA, and I feel very special because I think I'm the only man presenting here. It's only been women. So I suppose that has to do with Women's Month. I'm wondering, I need to have my slides, so I've sent them to 10 different people at CGE, but still they're not popping up. But anyway, just to really appreciate the opportunity to stand before you, because this work, as DDG Shoki has mentioned, it's done in solid collaboration. And I think we're very privileged that we could be asked to support the government. UNFPA basically work in support of government of South Africa. And I always say that we are working for the government. The Department of Social Development contributes money, like almost R1 million every year to the UN, particularly to UNFPA, so that, you know, we can continue the work that we are doing. Of course, South Africa is a member state to United Nations, And so we always say, when you come to us, it's not an inconvenience. When we have the resources, they have to be used for the benefits of South African citizens. And while we look for the slides, but I think for us, it's just to give you an update where things are at the moment when it comes to the strategy. You've had the background, the reason why we need to have one. I think some presentations earlier really did show that, the numbers may be decreasing, but still the rates are unacceptably high in terms of adolescent pregnancy. And we have to commend the colleagues that change this narrative around teenage pregnancy, because it's no longer teenage pregnancy, it's adolescent pregnancy. These are 13 to 14-year-olds getting pregnant. We also have, of course, 15 to 19-year-olds getting pregnant. So what I will do, I will quickly go through where we are at the moment and why we needed the strategy and what it will include. The consultation process, I think a good chunk of it has been covered by DDG Shoki, but also what are some of the outstanding issues, because that's where we really need your solid input. And I think the next steps have been also captured nicely. So in terms of the data, this is no surprise to some of you that the numbers are going down. I think we are glad to see that. However, we still have unacceptable high rates when it comes to, adolescent or teenage pregnancy, because this impacts on the health and well-being of young people. It affects their social as well as economic, status and issues. Being a teen mom, it's not an easy thing. Drop out of school, we hear about that. But also that we want to accelerate the response. There is great response thanks to the leadership of government, I think, under the Department of Women, Youth and Persons with Disabilities, but we still need to do a bit more in terms of accelerating how we respond. But we also need to know where we need to be responding, because again, we can't just aim everywhere. We need to be targeted in terms of our response, understand the geographies and where the disparities are taking place. So in terms of what's been happening, given the recent decline and where we are, the NSP really will provide us a structure for how we can measure the impact of our current responses, in terms of addressing the scourge, but also what resources we will need to have, because we know that resources are very constrained. So NSP will have to give us exactly where we should be targeted. We need to have very good data that can help us understand which ward really has high chances of young people getting pregnant, so that at least we can really be more focused and be intentional about redirecting the resources. So we know that while adolescent pregnancy affects 10 to 14-year-olds, it is also an issue that affects a large chunk of the 15 to 19-year-olds. And the NSP really will guide us in terms of how we respond. So it offers us an opportunity to consider this cohort of young people and their special needs in a way that at least we can hear from young people what can work best for them as we respond. So I just want to share with you that there will be a technical report that will accompany the strategy. And I think the vision in terms of what's guiding the strategy, the frameworks, the policy framework, but also the results framework. I think a lot of the background work has been done, and you will see where the gaps are and where we need support around the M&E as well as the costing aspect of it. There will be a companion report to help shape how the strategy will be utilized. But also the NSP should be the plan, and also just have enough information to make us really be intentional in terms of how we're responding to the challenge we're facing. There is a draft already. Large number of colleagues have commented on it nationally. We still need more inputs. And again, I've talked a lot about the technical report, which will have a bit more detailed information. Now, in terms of where we are, what has been done, I think in a nice summary, DDG has shared exactly where things stand. We've consulted with government, with also the children's sector, with GBVF sector, but also with SANAC. We've engaged civil society, but we still need to do a bit more so that people can see themselves in the strategy. It shouldn't be a strategy that the Department of Women, Youth and Persons with Disabilities went with UNFPA in a corner somewhere and developed it. It should reflect all of South Africa, in totality. As well, of course, engaging our, multilateral organizations, the donors and so forth, so that at least they can also give input. I think you've heard that the task team has been formed post the Indaba that took place in December. And we're pleased that also colleagues from CGE are part of and members of the task force team. And really, we do value your input in making sure that the strategy is reflective of what South Africans want to see. There's been a large sort of consultations in the country nationwide, but also just last week, KZN, which I think DDG Shoki spoke about that in terms of just the importance of making sure that we reach everyone. So one of the biggest challenges is also trying to figure out, once the strategy is developed, where's the best place for it to be situated so that at least we can hold each other accountable. We know when you think about the national strategy on HIV, STIs, and TB, SANAC is kind of the custodian of that. We know that they're driving that. So there's been conversation here. We know the leadership and oversight sits and is led by the Department of Women, Youth, and Persons with Disabilities. But at some point, when it comes to the point of now implementation, we need to make sure that at least there's ways of making sure that there's a body or a secretariat that really drives this to go forward. The provincial mechanisms exist. We know that there's very cross-sectional departments that will be supporting this at the district, as well as local mechanisms that can ensure that there's implementation of the strategy. We want to bring in private sector. We want to make sure that civil society plays an active role in implementing the strategy. And of course, the communities as well as youth forums that exist have to own the strategy. So this is a governance structure that we've been thinking about. It's a multi-layered approach. But within UNFPA, we've come up with something called a Girls Partnership Platform, which is on your right, where we are raising money to address issues that impact adolescent girls and young women. In the first year, we've raised about $2 million, but the goal is to raise about 11 million by 2030. And all this money will be used to support interventions aimed at addressing issues that face adolescent girls and young women. And the idea there is that we will be layering in issues around health, issues around economic empowerment, but also focusing on issues impacting on education for adolescent girls and young women. It won't just be family planning and HIV. Issues of mental health will be part of this as well. So that's our vision, that there will be funds to help support any response aimed at reaching adolescent girls and young women. So it will be intersectoral in its format. We're trying to bring in as many partners as possible. We also have private sector that has contributed funds to this Girls Partnership Platform. And of course, the idea here is that it's something that, if it works well, we want to transition it to government to say, this is how we can raise money to ensure that we have enough support for this adolescent strategy or for the sexual and reproductive justice strategy that Cabinet has approved. So that's the whole premise behind this. At the moment, the Girls Partnership is chaired by the Deputy Minister, Steve Litsike, as well as the United Nations Resident Coordinator, just at a political and governance level. But of course, we're bringing in all the other government departments to be behind it. So I just want to share with you in terms of what's happening with the strategy itself. At the moment, a lot of writing has taken place, led by our lead consultant, but there's still some blind spots. When you think about the M&E, that's where we need the support of key stakeholders. We are looking at having two goals. The first goal is to reduce adolescent pregnancy, and the second goal is to reduce the adverse health, education, as well as social impact of adolescent pregnancy. So when you look in terms of the data on goal number one, currently we're using the DHIS as well as census data, but we need other mechanisms of obtaining data to make sure that at least we have enough information to have an impactful national strategy. And also, the target proposal over the period of the strategy, we want South Africa to help reduce the adolescent fertility rate. So we need this data and information, and we think that a lot of key players who deal with data can support in that. And when you're looking at goal number two, we have the confidential inquiries into maternal deaths data that is routinely disaggregated and is available. but we don't have official or routine educational impact data. So we keep talking about the dropout in schools, but I'm not sure how easily that data is available, as well as ad hoc survey-based data. Only that's what we have. So we need robust data to really help guide our interventions. So in terms of the target proposal, we're looking at having disaggregated CEMD, which is a confidential inquiries into maternal deaths data, to help us understand the baseline. So this is kind of where we're stuck right now. We need to bring in the data people from governments to help us do clear target setting, to know exactly what we're dealing with and come up with the right indicators. The indicators are already there in different government departments in terms of what they plan to do when it comes to adolescent pregnancy. But we need to all sit in a room to understand which indicators should we prioritize and what should be the baseline. So this part is still very much a blind spot within the NSP development. And we're hoping that through your leadership at CGE and other colleagues, we can really sit and really do that target setting, because those have not been done yet. And on this slide here, I want to share with you, we're also thinking very robustly about the cost of the strategy. We don't want to just have a strategy in vain, but it needs to be costed. So we know what will it take to implement it. So this should cover either as new programs or as services only, but also departments must indicate what is mandated for them as opposed to newer things, but have a subcommittee that can really guide in terms of how should funds be channeled to support the strategy. So the framework of the NSP is looking at about 5 things where we want to educate and empower our young people, looking at protecting them and their rights, but also providing the services that they need to feel empowered. And then the 4th is how do we support them? I think we've heard a lot about what government departments are doing to support young people, but also to ensure that we can have an enabling environment that can allow them to grow up as young people, to not be worried about if they do get pregnant, they won't be allowed back to school, or how they should navigate their lives after they've gotten pregnant. So these are things that we want to be able to do, but we also need to understand the cost implications of that. So we need to leverage on existing resources and structures. That's how we really don't want to see this as a strategy that just operates in isolation. There's already a lot happening in our country. It's a question of how do we leverage on existing platforms. And also, we need to use existing indicators. I think on the M&E part, we don't want to reinvent the wheel. There is no need to start new indicators. They are there. Let's use what exists and let's just strengthen it. And I think that's really the firm belief. So for the costing for this NSP really would look very different from other incremental service provision of NSPs. So without the department inputs, it's really going to be impossible. So we will need government inputs in terms of what are the cost drivers. So we will be meeting with different finance officers of the departments, Department of Basic Education, Health, Social Development, DWIPD, to give us a sense of the cost drivers that are already in place, so that at least as we put this in front of you all, you know what it will take to implement the NSP. So that is in a nutshell what I just wanted to share with you. You've seen the timelines. DDG has highlighted where we are in terms of the next steps, but really we are on track. But of course, it will take all of us to work on this together. It's not a DWIPD only strategy. It's a nation's strategy that needs all of us. And I think we're very honored and privileged as UNFPA that we've been asked to support this process, but we're trying to be as consultative as possible. Even within the UN family, we have WHO, UNICEF, who are a big part of this, and also we have UNDP that we bring them on board to be part of this as well. So with those words, I just want to thank you for the opportunity to allow us to present. Thank you.
Oh, colleagues, thank you, Tulani and DDG for, I think, this authoritative presentation more than anything. That is the takeout. Insofar as monitoring the implementation of the NSP and also alongside the work that is being done on the strategy for the learner pregnancy development nationally. Of course, it being led by the Department of Women, and it being carried out by UNFPA. And these are the developments that are happening in the country. I don't even want to say this is an announcement, but I think this is really a tracker to say what is it that from a monitoring point of view the department is actually doing to ensure that there is a coordinated approach, I think, in the main, in eradicating the scourge altogether. And Tulani, we've actually heard the call that you are putting out, asking the key players to provide the necessary data that is needed. And I do want to also really provide commitment that CGE, yes, of course, the doors are always open. And if there is any further kind of support that is required, the institution is more than capable to actually give commitments toward what is being done. And yes, so that is actually taking us to the lunch break, colleagues, and I do want to believe that we are going to just take that 45 minutes and immediately find our way back into the room so that we can continue with the presentation for the day. And I think lastly, DDG Shoki, thank you for the commitment that you have put out in actually hearing out, the learners on the call that is being asked for a toll-free that could really assist in being, I think, a bridge between the learners and all these stakeholders that are supposed to be the key players in ensuring that reporting is actually, being accessed. And we really appreciate the commitment that is being made to say this is something that could be looked at. It is not something that is far-fetched. However, it needs to be thought through so that it can be integrated perhaps into the existing provisions of the toll frees that could be there in the country. And I do want to believe that there could just be a feedback in due time, DDG Shoki, should there be anything of that nature. And I think that feedback could always be given back to Department of Health, Social Development, and also basic education, and along the public education awareness that we would then need to, in due time, ensure that this is actually known as a provision that is out. With that said, colleagues, let us put our hands together for ourselves, for being a good audience, and then lunch is being served at the dining hall, and we should then be back from this venue at 2:05 so that we can continue with the program of the day. Thank you. Yes. Yeah. To Jamila? Okay. All right. The colleagues from the Justice Cluster and civil society, I'm really asking that you send your presentations to Jamela B at cge.org.za. I repeat, it's Jamela B at cge.org.za. We really apologize for the technical glitch that we've experienced since the start of the program. Thank you. Colleagues, before we lose the room, I do understand that this is an afternoon slot. I would have loved to start by maybe just taking a few Q&As, but again, I'm going to just suppress that thought and rather start with just taking all the departmental presentations. This afternoon session is comprised of I think just 3 presentations, but then grouped within the justice cluster. So we're going to have a presentation from the SAPS, and then it's going to be followed by the National Prosecuting Authority. And from there, I don't know whether I should open a Q&A part before I bring in a presentation from civil society and from, youth representatives, and then we then take questions and maybe map a way forward. I'm just tempted to do this so that we don't lose the conversation. And then in the end, we then actually then, start to engage. Is that okay, colleagues? All right, thank you. So with that said, I'm going to be asking us to just come back into it, and again, still welcoming the stakeholders online and the ones who are actually in the room. We are going to take a presentation on gender-based violence, sexual exploitation, and teenage pregnancy from the South African Police Service. And I do apologize, I couldn't get the name or the title of the presenter, and I will then get that, information as we move along. And followed by the National Prosecuting Authority. And if we can then just take those two presentations in that order. And do we have SAPS? It's online. Oh, okay. All right. All right. You will then indicate if you are ready, technical desk. Otherwise, you can cue in the presenter so that we can start. Over to you. Thank you, technical desk. I'm just told that there is a bit of a glitch between the Teams Live link that we are currently using, not really linking up with the speaker from SAPS. But while we are trying to solve that technical error, I'm just going to be asking the National Prosecuting Authority to rather come in first so that we can be able to cue in the SAPS speaker on time. Thank you, colleagues.
Good afternoon, everyone, and thank you very much for this occasion, for this ability to actually address this very important aspect. And I'm sure it's going to reflect. There it is. Thank you very much. I'm Karina Kutse from the National Prosecuting Authority. I'm accompanied by my deputy, Advocate Jackie Trotsky. I am from the SOCA unit, Sexual Offences and Community Affairs unit. Advocate Trotsky is from the Director of Public Prosecution, Johannesburg, or Gauteng Local Division. We all know that the NPA's mandate is to institute criminal proceedings on behalf of the state. We also, the management of victims of GBV, including statutory rape, falls within the mandate of the unit that I am allocated to, the SOCA unit. Statutory rape, or let me rather put it this way, sexual penetration of a minor can fall in three categories. If a minor is or a child, let's rather call it a child, if a child is being sexually penetrated, a child under the age of 16, if a child is sexually penetrated without voluntary and uncoerced consent, that would always be rape, regardless of the age of the perpetrator. If the child gives uncoerced voluntary consent for sexual penetration and the age between the child and the perpetrator is 2 years or more than 2 years, then it is what we call statutory rape. In other words, statutory rape implies that there were voluntary uncoerced consent. If the child gives voluntary uncoerced consent to a person whose age is 2 years or less than the child, it's no offense. It's a complete offense. So we are not criminalizing sexual, and I don't want these children to listen too carefully. It's still not a good idea, no?
But yeah, so we don't criminalize sexual experiences or experimenting between children. The whole purpose of this legislation is to criminalize sex between adults and children. Remember that. So the age, 2 years and less, no offense if there was voluntary and uncoerced consent. Also, it's extremely important to understand what voluntary uncoerced consent means. It means the child was not groomed or coerced. Remember, grooming is a form of coercion. This child was not groomed or coerced in any manner whatsoever to consent to the sexual interaction. The courts had held repeatedly in South Africa where a child is groomed or coerced for the consent of the child for sexual interaction, that shows a guilty mind of the perpetrator, because the court says you're not going to groom or coerce someone to consent if you know that they will consent without that coercion. So any form of coercion will negate the consent. The consent will not be legal or valid if it was obtained by means of coercion. Also, persons under the age of 12 cannot consent under any circumstances. The NPA, of course, we play a vital role in addressing GBV and child protection, and we're also responsible for policy and prosecution. These are the acts that we primarily depend on, just in terms of Section 54 of the SORMA Act 32 of 2007. There are 4 reporting obligations that act specifically refer to: the obligation to report suspicion or knowledge or reasonable suspicion of a sexual act against a vulnerable person. A vulnerable person is a child, a person with mental disabilities, or a category of persons under the age of 25. A category of female persons under the age of 25, also females 60 and over, and men 65 and older will also be considered vulnerable people. Then you have to report child pornography, and of course service providers also have an obligation to suspend services where child exploitation is taking place. And here are the stats. This stats refer to only the lower courts. In other words, the district court and the regional court, and this is from the 1st of January 2026 to the 31st of July 2026. If you can see, most of the charges that we prosecute people for would be for the act of sexual penetration. All the cases all the cases here refers to statutory sexual offences. In other words, where there were voluntary and uncoerced consent, but the age difference between the two was more than 2 years. So these are not stats referring to rape or sexual violation without consent. This refers to consent, consensual sexual acts. And if you can see, most of the registered cases would refer to the act of sexual penetration, in other words, statutory rape. Because those are the cases that we're more likely to see due to teenage pregnancy. So very often a child becomes pregnant, and it's only then that we realize an act of sexual penetration had taken place. And that is also why you see the numbers in terms of the act of sexual penetration so much higher than the act of sexual violation. If you can see on top, the second column, open district court cases. District court cases will be cases where the penalty would not be above more than 3 years. If the penalty is going to be more than 3 years imprisonment, then of course the case would be heard in the regional court where the jurisdiction is up to 15 years. Unless it's a prescribed sentence, and then we can sentence up to life in the regional court. Then also, if you can look at how the cases were disposed of, again, you find that the act of sexual penetration, consensual sexual penetration is much higher. But as I said, the act of consensual sexual violation is much more undetected than the opposite. If you can also see district court where the sentences are 3 years or less, they had 100% conviction rate. And in terms of the regional court, an 88% conviction rate, which is very, very good. I have to say that I started with GBV offences many, many, many decades ago. And at that point in time, the global as well as the South African conviction rate for rape, in other words, consensual sexual act of sexual penetration without consent, was 40% or less. We now stand at 88% or very often above 70%. Our target is also now 75%. So you can think over the last 30 years, we really have improved tremendously in terms of our ability to prosecute these cases and to understand the complexity behind it. I also always say that in the early 90s, I called myself a specialist sexual offences prosecutor, and everyone laughed at me because they didn't think that sexual offences was anything that one needs to specialize for. I felt very strong about it, that it is a more complex prosecution than most fraud prosecution. I mean, I did do serious economic crimes prosecutions, which I don't find anything as difficult as a sexual offence. But in any event, as I say as well, 30 years later, here we stand, government understands sexual offences and the victimology and the victimization behind it require specialised knowledge. And that is why people like myself in this field now do get specialised training to be able to deal with these cases. And I think the NPA, SOCA, as well as everyone else, we deal with the same problem, the underreporting. And all the challenges, basically, that we reflect is as a result of underreporting. There are various reasons why people don't want to report. I see in terms of the management of teenage pregnancies that we do at the Thuthuzela Care Centres. You know that we have 7 in Gauteng. I see there that in most instances where the child comes for a TOP, the partner or the father is less as a boyfriend and less than 2 years older than the mother. So it very seldom relates in prosecution because, as I said, that's a complete offence and we cannot prosecute that father. But there are also stigma attached to it. And I'm very, very happy when I heard this morning the first speaker indicating that the percentage of children that return to school, because it is just inconceivable that the child can set out in this day and age without a matric. We've already spoken about the reporting obligations in terms of our Thuthuzela Care Centres. I'm the provincial manager for the Thuthuzela Care Centres in South Gauteng. But in terms of that model, we're trying to cooperate all stakeholders to ensure that we all understand what is required and what is needed, not only to combat child pregnancy, but also to prevent it. One thing that I also think we need to bring to the table, and I say specifically, because one of the specializations that I do is the non-accidental baby deaths. In other words, children that dies, or babies, I'm only referring to children under the age of 5 years old, that dies of inflicted injuries. We can't just look at child pregnancies and see a mother that cannot cope. And you've seen with the statistics here how many children elect to have that child. We need to provide support. If that is the decision that they want to make, we need to provide support. We cannot leave a child with a child. And I have done other engagements with teenage pregnancies where teenagers indicate that they did abuse their baby once it was born. And unfortunately, as a prosecutor, that is what I deal with primarily. And you'll be surprised to see what people are willing to do to their children. I mean, we've had a case recently in the High Court where the child was really boiled from the inside. But let me not completely, where the parents pouring hot water into the baby Daniel, I think his name was, into his throat. Again, it does not relate to poverty. Don't think it's the poor people that do it. It's not. But yes, it's people that feel, it's mothers that feel completely they cannot cope with motherhood. So we really need to place support for that newborn baby on the program, and we need to discuss it. We cannot leave that child alone with that child, because it does relate to severe child abuse. We also deal, unfortunately, very often with victim intimidation that causes withdrawal. Very often the perpetrator or the father that impregnated the child, the family does rely on that income, and that intimidation, that person can very easily intimidate. The Tutusela Care Centres, it's a one-stop service centre where we do provide integrated, victim-centred and trauma-informed support. Also, barriers to, as I've already indicated, that underreporting is a problem for all of us. And I do, however, think that people do not understand the legal duty to report. Not only do we have to report in terms of the SORMA Act, we also need to report in terms of the Children's Act. And all categories sitting here has an obligation to report knowledge or reasonable suspicion of child abuse to the Department of Social Development. We also, in terms of the Tutusela Care Centres, wherever a reporting had been made at one of our centres, we do provide feedback, and we find that that feedback is specifically the reason, or the lack of feedback is specifically the reason why people lose interest in the criminal justice system and does not want to participate. We have to collaborate not only with our interdepartmental, but we also have to collaborate in terms of public-private partnerships. We also need to provide better data sharing or data collation, only in terms of evaluating our data, which we really understand where the gaps are and where the challenges are and how we can confront them. The recommendations enforce mandatory reporting provisions or strengthen the knowledge of that. Streamline case enrollment procedures. I very often see where the TCC refer the case to SAPS. SAPS just never comes back with a CAS number, which is very important. Also, in terms of referring the case to SAPS, unless there's a CAS number, in other words, a case administration system number, reference number, and that is a number that only SAPS allocates. Unless that number is there, our forensic science laboratory will not analyze any DNA that we send to them. And very often in terms of child pregnancy, especially a TOP, that DNA analysis on the embryo, the aborted embryo, is extremely important in order to ascertain the perpetrator or to prove the identity of the perpetrator. We have, as part of our national strategy plan, to expand TCC model. I think our minister, as well as DSD minister, feels very strong that that is the best model, and it indeed is the best model in terms of dealing with GBV. We also need to improve support mechanisms, and as I say, I would very much like to see it the support extended to the newly born babies. We need to increase specialized training, community education, and the specialized training for prosecutors is not a problem in terms of the urban areas. It is a problem, however, in terms of our rural areas. Very often a rural court will have one regional court prosecutor. That prosecutor has to do everything. There's no time for specialization. So maybe we should do a national GBV prosecutors like we have with fraud, commercial crimes. I mean, they go out to that rural court to do the case there. Maybe we should campaign for government to do the same for the prosecutions and prioritize funding. I think funding is the one thing that we all would see to increase. Yeah, all I can say is every matter should be reported because every child counts. Thank you, colleagues.
Yeah, you really presented like a prosecutor, typical prosecutor, Karina. You were like jump, 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 jump. Case over. Thank you very much. Colleagues, I'm sure we can really thank you, the NPA, with that presentation, which I think is really raising an uncomfortable, depending on how you tend to, or how you may want to look at it, but the aspect of consent, coercion in relation to the issue of age, right, of these two. I don't even want to call them partners or parties, because honestly, 10-year-old and a 10-year-old, I don't want to call them as partners. Maybe they are really parties. And this 2-year age differentiator is always a bone of contention, Karina, when we raise awareness in communities, especially in rooms where there are parents. They will then want to actually, abuse you for you coming to actually tell this truth. But the good thing, when we go to outreach initiatives of this nature, we always bring, subject matter specialists, in this instance, from NPA and SAPS, so that communities may get to really hear this from those policy crafters and implementers, just from a knowledge point of view. And I know what you meant when you said you don't really wish that, the youth here can really, understand what this means, this 2-year, age thing that is actually put out by the SOMA. So moving along, colleagues, I see that you also made some recommendations, which I think, again, come back to the same aspect and the principle of care being, child-centered in anything and everything that is being done, because we are, again, talking about children in this instance who you really may have violated the law, but you're still coming back to the aspect of ensuring that there has to be care, because there's always a benefit of doubt that others may not have understood what they were doing, their implications and consequences. And that is why it becomes imperative that care is really put at the center of whatever response plan that could be put out there. With that said, colleagues, we are going to move along. I have just been informed that we are really struggling technically to put out the SEPS presentation, and they are sincerely apologizing for that. what we may just need to do is to just include the SAPS presentation amongst other presentations when we actually put them out in our website, and when we do email these to the stakeholders, we may want to provide a link so that we can have access to all these presentations. And when we do that, we are going to include the SAPS presentation. We really apologize for this glitch, colleagues. Technology is beating us when it comes to this area, despite the fact that we have a quite competent IT desk at the back, but technology is really actually showing us who is the boss. And colleagues, somebody has dropped the, what do you call these ear thingies? Oh, okay. So I was going to ask if one can actually, indicate what this is for, but I am seeing that there's a hand coming from the back. And moving along, colleagues, I know that we have acknowledged the presence of JPMD earlier on, and I'm putting this into context within the same line of us not having SAPS in the room. And I just want to take this back again to the learners to say, we understand that in Johannesburg, we have a privilege compared to other towns or other cities of having an extra layer of law enforcement, and we have JPMD amongst us. And JPMD, if there is a word that you may want to give back to the children, or rather to the learners in the room, what would be that one advisory based on the work that you are doing daily? What is it that you may want to say, look out for this, it could protect you? And again, taking it back to the learners, what is that one request that you may want to put out to JPMD? We do understand that sometimes we go out at night, and like any other young child, and we experience what we are experiencing. What is that one request that you may want to actually advance to law enforcement now? And maybe you may not want to look at them as JPMD, but law enforcement. And what would be that? I'm just going to give one of you, the colleague in front of me, and just one learner, just to talk each other. Thank you. You can come this side.
Hello? Oh,
Yes.
yeah, there we go. Good afternoon, everyone. Thanks for the invite. It meant a lot. I'm Officer Kiet from JMPD, not JMPD, Johannesburg Metropolitan Police Department. So thanks for the invite, guys. It means a lot. We are part of the guys that are on the ground. Remember, we patrol day and night. We see things, and the eyes and the ears on the road. So guys, the advice I have to give you, we all are vulnerable at some point in times of our lives, right? To the point where we hand ourselves over to the perpetrators freely, willingly so. And when I say this, I'm just going to mention part of the areas that some of the things are happening. We've got places like your Braamfontein, where there's a lot of student race there. Guys, the things we see there, you guys are living at the race, but the guys that are moving in and out at the race, it's like, it drains me as a parent and as a law enforcement officer. There's men moving around, there's men moving about. You guys are making yourself vulnerable to these people. Remember, because now you want to have McDonald's to eat, you want to drink, you want to socialize, you want to be that kind of person, forgetting what you are there to do. Some of you come from as far as Limpopo and wherever else to come and study. Guys, focus on what you came for. Do you understand? If you are still a scholar like now, be there to finish school and move on. Forget about everything else. Everything else will still fall into place as you get older. But those things like getting an education, finishing varsity and those things, They don't wait for you. They move on. As much as partying and socializing moves on, because every time things change, things differ. But guys, you are here to focus. Do you understand? Those guys are just here to use you. Today they're going to use you. Tomorrow they're going to use Yolene. Tomorrow they're going to use Jackie, and the day thereafter, and so forth and so forth and so forth. Do not allow that. As we are talking about teenage pregnancies, we have kids that come to us every day that cries and says, guys, I was here to study. I was here partying. I was doing 1, 2, 3. I'm scared to go back home to tell my mom I'm pregnant and I'm at this race or I'm at school and it's not supposed to happen. I am, as a law enforcement officer, how do I advise somebody that lost track of where they're supposed to be going? Do you understand? It gets difficult out there. I'm not a person that fell into teenage pregnancies, but I've got relatives and nieces and nephews that got there. I know how difficult it is. It's very difficult, guys. When you get there, it's difficult. Sometimes you end up losing yourself because you're more focused on the child than yourself. While you have time to focus on yourself, focus on yourself. There'll come a time in your life where you focus on having kids, being a wife, being a stay-at-home mom, being a stay-at-home wife, and whatever not. But for now, guys, please, the streets are the streets, but they are not safe anymore as they were 10, 15 years. Let's make it even 5 years to 2 years ago. The streets are not the same. They will never be the same. Perpetrators become more smart than us who are policemen every day. They outsmart us. So we have to basically protect ourselves from these people. And the way we can protect ourselves is by making sure we do the 1, 2, 3 ABC steps that we are taught at home. Those are the basic steps that you can use in life. Thank you so much.
Thank you, officer, for that precautionary awareness. I am not going to dilute your words, but what I'm taking out as a key takeout is that learners officer is saying, understand one thing, that perpetrators are transactional. So you may think that you are just given a lift from one section of the school to the other, or this friend is just buying you a packet of chips, but you must always, at the back of your mind, understand that this is transactional. More often than not, this is transactional, and this could lead into unwanted and unwarranted repercussions. So carry that as you move along and understand that the world is no longer safe out there. And when we say this, we're not apportioning blame. We're just saying the world is not safe. Keep your eyes open so that you may not end up getting harmed. Thank you. I'm trying to be very careful and selective with my words when I say this so that I don't get to put blame on anyone else. And thank you, officer, for that awareness. I have just been informed that the school is almost out and that, learners have to adhere to the schooling times and they are going to just exit the room when it's due time. And when they do that, we just also want to really take and put out a word of thanks to the educators and to the Department of Basic Education for allowing us to actually have a conversation with the learners. We understand that priority is always placed on curriculum because outcomes have to be all about education. They must pass, but we understand the nuanced nature of what they are dealing with daily, and we really thank you, department and the learners, for actually being part of this broader conversation. We've heard you, and what you've advanced is something that we may not have been aware should we had not opened this opportunity to actually engage with yourselves. And with that said, colleagues, I think let's just put our hands together and thank you. Check if there are any questions that may be on the chat so that we can, as we bring forward the community or civil society representative to give us presentation on family and social factors influencing teenage pregnancy, that we may just maybe look at those questions. And I don't know if the Department of Basic Education didn't have any other questions that may not have been addressed. If there is a question, then this is an opportune moment to actually take those. So you may just indicate to the teachers and the learners going once. If there is any question that you may have want us to look at, please talk to us. And then if not, as you are journeying back home, you may then just put those questions on the chat. We will actually provide responses, and the technology should be able to really interact back, with you. Moving along, colleagues, then I'm going to be asking the presentation from, I didn't get the name again, from the civil society rep that is in the house to just come forward and to give us that presentation. And that is going to be followed by a youth representative presenting on the adolescent voices and lived experiences. Thank you, technical desk. Thank you. I've been told that the youth reps unfortunately also had to leave during lunchtime because the sponsored transport was actually timed, and they will then again forward the presentation to us, and we will put that presentation into the pack link that is going to be sent to everybody who's in the room. Now, colleagues, it looks like we have come towards the end of the formal presentations. And just as I was about to ask for a question and answer session, the SEPS colleague managed to actually come back to the line, and we are now going to have the presentation that we packed earlier on from SAPS. And over to you, my colleague. Thank you.
Indicate that we're requested to provide a presentation on the key policies and compliance with applicable national frameworks on teenage pregnancy, or should we say adolescent pregnancy, which in our context would be statutory rape in our context. And to just start off by saying that the South African Police Service is very mindful of the complex societal nature of teenage pregnancy or adolescent pregnancy, as well as the related situation of statutory rape, and that it requires a multidisciplinary or multi-departmental approach, much as other colleagues have already indicated on this platform. That because the causes are quite complex and tend to reach into what we had earlier on as some of your socio-economic situations. There's been reference to the issue of transactional engagements, as well as some social pressures that you may have regarding sexual action by young people. Having said that, a lot of what was indicated by my colleague from National Prosecuting Authority actually provides the mandate, the policy mandate, which would start with, the constitutional mandate of the police to prevent, combat, and investigate crime. And also the whole issue of legal or legislated mandates that are indicated in the Criminal Procedures Act, defining statutory rape, as well as the criminal law, sexual offences and related matters legislation of 2007. That has already been covered, and with regard to how it is defined, but we can also indicate that the other exceptions that are provided by Section 15, which is, as we have heard from our colleague at the NPA. And I must also indicate that it goes further and indicates for all persons with knowledge of sexual offences having the obligation to report such knowledge to a police official, and that non-reporting constitutes an offence, and the person would be liable for a fine or imprisonment. Again, this is in the next slide, supported by the whole provision under Section 110 of the Children's Act, which really obligates teachers, a whole range of people, adult people, including teachers, medical practitioners, social workers, traditional authorities, religious leaders, to report when a child is abused or deliberately neglected. Now, this is also supported, how we translate that in the SAPS into policy is through the national instructions or SAPS directives, as we may call it, including your sexual offences national instruction 3 of 2008, the national instruction on the care and protection of children, 3 of 2010, as well as all the other national instructions that basically obligate us to treat victims with sensitivity, respect and dignity, because it is a way of encouraging victims to come and report and to try and remember all the details of what actually happened to them when they make that statement. Basically, we also have a policy as governed by the Victim Empowerment National Instruction that says that we should try as far as possible to ensure that this victim, a victim of sexual offences and any other sensitive crimes should have their statement taken in private, again, as a way of not only protecting their dignity, but also to ensure that they are in an environment that is conducive to them actually explaining their experience and remembering as much of the detail as possible, so that that can go into the statement and the docket that will be used in court. Now, I must mention also the national directive relating to children in conflict with the law. And the reason for that is that we have also found that we are getting a greater number of children who are actually themselves sexual offenders. And this directive would then provide for all children who are in conflict with the law. Now, we, of course, support this by training on skills to enable performance of obligations and provide our members with the knowledge on how to go about addressing the different issues. Now, there are two key approaches that we would utilize, which is your proactive approach as well as your reactive approach. Basically, the proactive approach is one where we look at your preventative partnerships, of course, with key people who would be able to assist us address all the factors that contribute to whatever crime that is being experienced. And the reactive approach is where we are investigating a lot of investigating what we have had reported to us. Now, in terms of statutory rape, I should mention that we have a specialized investigation unit called the Family Violence, Child Protection and Sexual Offences Unit, or FCS, as we call it. Basically, it's been in operation since 2006. It's predated by your Child Protection Unit. And we've had the re-establishment of FCS units at every police station so as to provide that specialized investigative capacity on people who are trained to actually be able to speak to young people and children and to actually address the issue. We also have forensic social workers working within the FCS mandate who are specialized in providing, your assessment reports. They assess the child victims and witnesses on referrals from the investigating officers. And of course, that is all collected into the docket that is then given to the NPA for them to decide on whether they will prosecute or not prosecute. I think, Karina, I think it was, has already talked a lot about what happens with regard to your issues of consensual rape and those aspects of the ages that go into the issue. But these issues are always then taken to the NPA to then decide on whether they'll go ahead with the prosecution. Now, basically, what do the investigators or detectives do? They will interview your witness, interview the victim, assist them in getting a medical examination conducted, which will be part of your docket, as well as utilizing investigation aids and experts, and then identifying and apprehending or arresting the alleged offender in order for them to appear in court. Somebody coming to how do we receive our reports? Various ways. There are the walk-in to the care center where they are available. And again, as I have indicated, we prefer that everything be interviewed within a victim-friendly room that is designated. Where there are no designated victim-friendly rooms, alternative arrangements are made for the interview of the victim. Somebody asked at some stage regarding the helpline. You may also report on 08600 10111, which is just basically the line that we use when you need to indicate your knowledge of a crime that has been committed. But emergency reports are made on 10111, or you could just phone your local police station. I also would need to indicate that we have what we call the MySAPS app application, which can be downloaded on phones. And then you can provide your report that way online and speak to a professional who would assist you. Now, having said that, we're going to the Safe Schools program. We have a protocol on safe schools with the Department of Basic Education. And basically that is a collaborative partnership where we would be able to visit schools, provide them with information, provide them with preventative tips, basically to ensure that they are aware what issues, what constitute what crimes. We participate in programs around also bullying, gangsterism, or any other, or the use of drugs, any other issue that can lead or contribute to a person committing crimes. Colleagues, if I could just say, and our young colleagues as well, I've sort of skipped a number of slides, and if we could just get to the slide, please, that is with regard to sexual offense statistics regarding young offenders. That regarding the spike I was referring to earlier on, that we have over years observed a spike, an increase in statutory rape cases where young people are actually involved. In the year 2024 to 2025, SAPS received and captured a total number of 2,826 criminal charges against children on sexual offenses, as compared to the 2,438 in 2023-2024. We noticed, of course, that in the majority of cases, this would be male offenders as compared to the female offenders. And of course, we must also mention that we are not sure to which extent those were committed against other relatives or other young people, because it's a range of people that it gets committed against. Now, that was an increase in 2024, 2025, and it is in our interest with all our partners that we actually establish what factors have contributed to the spike. Now, if I could come to the last slide, please, regarding our challenges. It is most likely also that the whole issue of underreporting has also contributed to the increases that we see. The big challenge with underreporting, I think other speakers have also related to these issues. It's due to your social reasons, cultural practices, dependence on the perpetrator of sexual exploitation. I think that Chair was also relating to the whole issue of your transactional relationships. Families who are affected by fear of the perpetrator, particularly if it is somebody who is a celebrity within the community, or stigma, or just lack of knowledge that it is a criminal offense not to report. Mandatory reporting is also not universally practiced. And we do know, I think, due to some of the reasons that have been indicated by earlier speakers, but also ethical concerns. For example, some health professionals will indicate that they feel it discourages the public from accessing healthcare if they have some dependence on the perpetrator, or if they feel they are compelled to report. And then exposure of young people being taken through the criminal justice processes would be some of the reasons that some educators advance in this matter. And I think one would align themselves with what the NPA colleague had indicated, that people should differentiate between an obligation and issues that say you may or may not report. Reporting is a legal obligation, and failure to do it is a criminal offense.
Colleagues, I don't want to take much time, but just want to actually thank the section head of SEPS for the presentation that has just been made. It is really giving us a way forward in terms of what is it that we need to look at from I think, constitutional duty to prevent and to combat teenage pregnancies and statutory rape thereof. And if you listening carefully to the presentation that SEPS is making, is actually tying very well with what NPA had presented earlier on. So colleagues, we may just maybe put our hands together for the colleague's presentation. And thank you. While we are actually asking Komsa Mai to come forward, I do want to indicate, colleagues, that we are going to just take few questions from the floor, because we have already started doing so during the day, encouraging just a robust engagement so that we don't just bombard the Imbizo with just presentations and not engage. So with that said, I know that Komsa Mai, you are actually rushing for your flight out, but I am going to give time to the Q&A so that in your way forward, you may also be capacitated with some PATCOs that we may need to take out in actually wrapping up the engagement. So I hope the team has got the microphones so that we can take those questions. I see there's a hand from the, let me start at the back, Doc. I am noticing 3 hands from the PM Gauteng, followed by the colleague behind her. And we also have a hand from Dr. Oveni. I do really encourage us to really interact, colleagues, so that we can be able to get to take out those matters that are actually bugging our chests, and we may be able to find a solution. Thank you.
Thank you, Chair. Thank you, colleagues. I'm Spio Machoba from the Department of Women, Youth and Persons with Disabilities. I just wanted to say quickly, Chair, it's not a question, but just an important statement from us. That is the drafters with the NFPA of the NSP, to say that our request is the following. We are going to disseminate our draft report, which will be a draft 1, to colleagues to respond to, either as individuals or representing the organizations, so that we can strengthen the NSP, because we don't want what is said here to be lost and not find itself within the NSP. And also part of the issues that are going to be very important is that, one, we really want an integrated, non-fragmented approach, which includes government and civil society and NGO articulation into the NSP. Because what we are mostly worried about, as I conclude, is that we want to have an architecture of implementation which will exactly heal these silos that have held us back. Because I think if you've listened, you hear what departments are doing. They're doing good work, but it's not impactful to an extent because of the silos. We don't know who's doing what where. You see that people are very busy and money is being spent, but we need to see value in that. Hence, we are saying we want a non-integrated approach to this. So if you can also advise on a structural configuration that can ensure that we work as one solid unit, I think that will be appreciated. Thank you.
Thank you, Spio. You are very loud and clear. The call is out.
Thank you very much, Program Director. I honestly don't know where to start, but I'm glad that Mr. Machoba went before me, because a lot of the issues he's raising as someone who works in government, I appreciate that they are coming from him. I have a long list of issues because when I get into a room with officials of government, what I expect as someone who works for the Commission for Gender Equality is accountability. And I am hearing that resources are a challenge. They've been a challenge since I joined the sector in 2013 when I was beginning to work. I did not hear anything new. These have been the challenges, and the responses have somewhat almost been the same as well. The issue of the NSP, it is welcome. We should be seen to be doing something, but are we not reinventing the wheel? How many plans are we going to come up with as a country before we see real impact and real change? It's really concerning, because we are talking about children here, some who cannot even speak for themselves. We've been on the field. Children are being sold so that a family can buy maize meal. And communities are watching. The police are watching. Social workers are there. And there isn't much that seems to be done. I wanted to ask this question because we are told that it is an offense if an adult knows of a child being sexually abused and not reporting it. I'd like to see the statistics of how many adults, including officials as listed in the Act, have been arrested, at least in the past 2 financial years. And again, on the issue of resources, it is disheartening because we are also a country that talks a lot about corruption. How many resources are being drained because of corruption that could be channeled towards some of these initiatives? Children are being turned away from school despite the policies, despite the many frameworks and documents. Children are still being turned away from school. The report by the CG is not very old. I think it's from 2023. It shows that, especially in the Eastern Cape, you must pay someone to accompany you to class. And if you do not have those resources, you cannot be in school. Educators are saying we are not social workers. We are the social workers. It is not our responsibility to manage pregnancies. We are here to educate. That's what they were saying in the research. It's a long list of issues. TCCs, we see beautiful buildings sometimes, and there are no services being rendered because of the failure by departments to coordinate themselves and work together. To date, they're still arguing around who is in charge of running TCCs and coordinating the sector to ensure that services are rendered to date. SAPS, a few months ago, it's documented. We have over 10 years of research, over 10 years since I joined the CGE. TCCs, not in Gauteng. I'm not speaking about Gauteng. I'm speaking about countrywide, that we've been to Free State, for example. Let me speak about the ones I inspected personally. When we got in, it was a beautiful building, but there was no nurse, there was no police officer. What we found was that there was a site coordinator and a social worker who was brought in by an NGO, not from DSD. Yet what does the model say itself? And we are saying it's a model that works and it's beautiful. Colleagues, I think if we really, really believe that teenage pregnancy, as we've been calling it throughout the day, was a crisis, we would be reacting as such. When COVID hit in 2020, it was treated like a crisis and we saw that real action was being taken. We were even policed. The police were coming after us for being on the streets because we're supposed to be at home. We're not supposed to be on the street. Why are we not seeing the same level of services being delivered at that level? I'm very passionate. I called SAPS a few months ago. I saw a body lying down. I wasn't sure whether the person was still alive or not. Then I decided to dial the number that was shared with us. The phone rang for over 20 minutes before I could hang up, and nobody picked up. Is this also an issue of resources? Where's accountability? Do people get fired when they are not seen to be doing their work? DSD, do we have qualitative indicators? Now, understand, it is true, there is a shortage of social workers. A few years ago, the minister had a program, I'm a beneficiary. We were taken to school so that you can increase the number of social workers in the country. It was done away with. So we remain a country with beautiful ideas and well-crafted documents. You sit in a room, program director at the AU, we are told, South Africa, just keep quiet. You are bragging, we know you, you have the best of the best. But do we really have the best of the best? Is that translating? We are failing our children.
Oh, I was still listening. Listening, PM, thinking that you are still on it. And I think I like the fact that you come just after Mr. Machoba. And I think in summary, Mr. Machoba, you can already hear what the monitoring body is saying insofar as a response to where we need to go, because the baseline NSP is currently in existence, and we understand that now there is a movement alongside, what the UNFPA is doing in terms of looking at a technical support on the development of the learner pregnancy national strategy. And already I'm sure you can see how CGE is going to respond towards strengthening the report itself, so that we may have some shifts, because we've got the baseline, information, as Naledi has indicated. Baseline information is there, but now this is just a question of perhaps putting the relevant stakeholders into one room so that we can actually strengthen the strategy that UNFPA and yourselves are doing. I'm not going to, yes, not that we're promising a new way forward, but I think this is the commitment that is actually coming out of the presentation, if I understand Naledi, or rather hearing her well. Moving along, colleagues, we have a hand on this side from Dr. Oveni, and there's also another hand. I can take up to 5 hands, and maybe we can then get another additional person so that we can ensure that we do not just get to speak amongst ourselves as CGE. We are opening this broadly to the room. And thank you, Senpax. So we're going to take hands in that order, colleagues. Thank you, Dr. Oveni.
Thanks, Program Director. My question is directed to UNFPA. I was quite curious about the NSP in terms also of the indicators. So maybe this is a conversation we can have online, just to understand exactly what indicators are included, how are they defined, and so on, because I only saw 2 projected there. And then I was also curious about the process of developing the NSP. I know Diekitsing was part of those engagements. Did you take into account other similar policies? Did you look at KZN's national multi-sector strategy? Did you do some international benchmarking? I think that would also be helpful. Thank you.
Okay, thank you, Dr. Oveni. I hope, Mr. Machoba, you've managed to capture those questions, and maybe you may not need to respond directly, but maybe take them as mtobiso, right? Part course in actually reviewing the processes, so that if there's any misalignment that could be there, that you may actually take consideration of what the colleagues have actually presented on. Thank you. Then we move along to my lady. Thank you, Notema.
All right. Thank you, Pili. The SAPS reported that there were about 2,826 sexual assault cases. And then the Department of Health reported that there were about 18,330. That is a huge difference in reporting them. That means there are about 15,504 unreported cases from what was reported by the NPA and the SAPS, pardon me, by the Department of Health and the SAPS. And we still have not discussed where is the gap? Why are these cases not being reported? It's almost, if I were to put it in percentage, I would say plus minus only 20% of the cases are reported. Where is the gap? Considering that Section 54, the amendment was introduced, I think in 2021, if I'm not mistaken, which is the duty to report. Almost 4 to 5 years later, we still have such a huge gap when it comes to reporting. And then my question to the NPA, if you may just kindly highlight what challenges do you experience when you are prosecuting statutory rape cases? So maybe that's where the gap is. And I saw that you also presented data regarding the conviction rate. What about the cases that don't make it to trial? What are the issues there? What is the rate of attrition? Does that speak to this gap that we're experiencing? Is there a need for a coordinated approach between you and the SAPS to address the gap of matters that don't make it to trial, or the matters that go unreported. So if you could just highlight in summary, what challenges do you experience that lead to these cases not making it to trial? And for those that make it to trial, what are the challenges that are highlighted there? Thank you.
Thank you, Notemba. It's a pity we've lost the SEPS colleague. However, if maybe she is online, I do hope that she may be able to just respond, even if it's by sending the response on the chat, because it is indeed true, Notemba, that if you look into that disparity between what Department of Health and SEPS and NPA are actually reporting on, we're seeing 18,000 versus the 2,000s almost a year ago, 2014, 2015. And there seems to be around 16,000 of cases that are not coming to SEPS. And as to whether SEPS is able to just respond on what could be happening, because we should have started at seeing close enough to those cases that are between the Department of Health and what is being received by SAPS. And we do acknowledge that NPA could be telling us a lesser number, because depending on whether they concede to prosecuting or not, but there shouldn't be cases that are lost along the system. And what we saw today, again, it really paints a big picture between what we see being reported to SAPS and yeah, if the colleague is on the line, kindly respond. And I also hope that NPA should be able to give us some responses. Thank you. There was also another hand, I should think, at the back. Oh, okay. Yes, I think let's take that question, and then we now take a round of maybe responses from UNFPA and also NPA. Thank you.
So I can respond Dr. Hoveni's questions. I think starting with the one around the benchmarking, let's say easier one. So the way we wanted to approach this is that there should be a way for us. I mean, we've looked at the best practices and looked at WHO guidance in terms of what it prioritizes, which is the intervention that are feasible, measurable, and linked to outcomes. So before all of this was started, we actually did a literature review, and also there was a paper that UNFPA did this year with Gates. So just to answer and assure you that we're looking at global best practices. I think there's been a lot of information shared with the consultant, and we're very fortunate that someone who also understands South African context has worked here extensively as a health economist with HERO. So just to respond to that question, that the strategy is grounded on best practices available within South Africa, but also globally. On the indicators, I think you're correct. I mean, you probably saw too, because that's still a evolving process. It's a process that we don't feel comfortable doing it by ourselves without extensive consultation. So right now, the M&E framework, I didn't present that slide, but it's basically, we have a list of activities. We have the 2 goals that need to be achieved. But more importantly, we need to sit down with the M&E directors from the different departments, especially DBE, DOH, DSD, DWIPT, to really agree what are the right indicators and also the target setting. And again, this is not reinventing the wheel, it's using what already exists in the APPs so that at least we can really hold ourselves accountable towards that, because ultimately it's supposed to complement what's being done already. So that's kind of where we are. The M&E has not been completed. We have 2 goals, which is to reduce adolescent pregnancy, but also to reduce adverse events of adolescent pregnancy, where we'll look at issues around reduce unsafe abortions, as well as related morbidity and mortality on those, but also improve maternal health outcomes through increased uptake of quality services. And other outcomes on goal number 1 is to increase reach and impact of sexuality education, reduce child marriage, reduce pregnancy resulting from sexual coercion and violence. So that's where the outcomes level, but we still need to unpack the indicators themselves. So the M&E framework has not been finalized. We need your brains to do that. Thank you.
Good afternoon. Yeah, if it comes to unreported, what we're trying to do, we have within the NPA a teenage pregnancy project, specifically where Department of Health and the NPA work together to ensure that all TOPs come to the TCC. But unfortunately, we don't have TCC everywhere. And I'm sure you talked about put it in Java, that one. That was established, I have to admit. We established that TCC before we made our calculations to fund personnel, which was, but it was civil society, it was the banking sector that actually established those TCC. So we didn't want the money to go wasted. So we said, yes, build. And then we will get to the personnel later. So I'm sorry, you were actually right. I was just thinking we did have problems in terms specifically in the Free State. Yeah, when it comes to unreported, so what we're trying to do is when the Department of Health refers a TOP to us, we will refer that case to the police. But unfortunately, that's the best we can do. We refer it to the police, but it doesn't necessarily relate to a criminal offense. It might be that the victim indicates that it's her boyfriend, she doesn't want to proceed, which is very often the case. And very often, you'll be surprised, but about 50% of TOPs are partners with less than 2 years age difference. I get the impression that teenagers are more likely to have a TOP if the father is also a teenager than when the father is an adult. Trial is very difficult unless, of course, we collected DNA during the TOP. So what would happen if the TOP, before the hospital would do a TOP, they would refer it to the TCC for the police to be involved and for a crime kit to be allocated, because you need that crime kit to allocate, to collect DNA evidence. Once we have DNA evidence, it's very easy then to put the perpetrator on trial, especially where the perpetrator is an adult. But where there is no DNA, in other words, where it wasn't a TOP, the child decided on a full-term pregnancy, they might give the child up for adoption, or then we can go and do DNA. It's very difficult to do DNA extraction during a pregnancy because you might lose the baby. So we have to wait until the baby is born and then do DNA to establish the identity of the perpetrator. But as I say, once we've got DNA, a trial is very easy to conduct. Without the DNA, you have to rely on the victim, and they're not always cooperative, especially where it's a boyfriend. If it was unconsensual, no problem. But consensual, there is a problem to proceed if there's no DNA to rely on. In terms of withdrawals, I think I'll give Advocate Trotsky that.
Thank you. Yes, we also do have a high withdrawal rate in these type of cases where the complainants are no longer interested in the cases and they want to withdraw, or where cases are struck off the roll due to the fact that the DNA is still outstanding. So what the NPA has embarked on, it's a recent project, is called the Withdrawal Project. I'm the nodal point for Johannesburg. The basic aim is to retrieve all these withdrawal cases, to go through it, to see whether the DNA which was outstanding has now become available. If so, then we relook at the cases and with the aim to enroll it back onto the court roll. Also to see sometimes the complainants are so traumatized that they do not want to proceed with the case. They feel the criminal case is just too much for their trauma and for the secondary victimization. They feel that they are not ready for court. So in those cases, because we are victim-centered based, you must always remember the NPA is victim-centered based, our victims comes first. So what we do is when at that stage, due to the fact that the complainant is not strong enough to go through a court case and emotionally ready to go through a court case, we rather withdraw the case and let her undergo the trauma counseling. We refer them for trauma counseling, and when they are ready, then we definitely enroll these cases, and our success rate is then much better in those cases. That is what I can say with regards to with the withdrawals. Thank you.
There's maybe also just one aspect that also make victims withdraw is specifically Johannesburg and certain areas around, and the areas around the Tutuzela care centers deals with a high level or high density of illegal immigrants. And it's very unlikely that someone that comes from a community of irregular and undocumented migrants would cooperate with the police. We find that they normally give the wrong address. So even if we do refer to SAPS, we very often get the wrong address because they don't want the police to come to their community because the community has undocumented and irregular migrants. So everything really fits in. It causes problem, even our migration problem, and the fact that we haven't really have put in measures to deal with that also relates back to our sexual offences.
Okay, thank you very much. I just wanted to correct and clarify the issue of the statistics regarding the question that was asked around the 18,000 deliveries that were not reported. In the presentation that was delivered, the 18,330 talks to your 10 to 19-year-olds. And among those, only 296, it's girls aged 10 to 14 years. And we know that with the Criminal and Sexual Offences Act, it talks to 16 years and below. Also, the termination of pregnancy among your 10 to 14, it was 115. So it's close to 400 and something cases. And this is only for Q1, which is April to June this financial year. So I thought I needed to clarify that. I know there's some discrepancies in terms of reporting, of which I cannot, I don't have the justification. Maybe the SAPS will be better positioned to correct this or to discuss this, but mine was just to clarify the numbers. Thank you.
Thank you, colleagues. I know that we can have a day and a night and still come back to it tomorrow because we are just at the receiving end of everything. And we see what we are seeing, and we wish to advance what we want to advance. However, I do know, also acknowledge that, the risk of time is another limitation that we find ourselves in, and we wouldn't want to keep everyone in the room beyond the time that we've asked, because we want you to come back again tomorrow when we really need a meeting of the minds. So I'm going to just ask colleagues maybe then suppress the questions at this stage. However, continue to put those questions forward to the person who was actually inviting us, so that when the research department makes its report, that they may have a view of what we wished to have addressed, for today. As we are preparing for Commissioner Samai to just come forward and agree or disagree with what was presented today, she's allowed to do so. This is the commission. I do want to also indicate that SAPS has just responded on the chat. However, I'm limited in terms of beaming that chat because the presentation is queued already, and I don't want to run the risk of losing it already because we've been delayed so much today due to technology. So there is a response that is actually on the question that was asked by my lady on the disparities on what Department of Health Social Development are projecting versus what SAPS and NPA are seeing. So the response, I'm told, to this question is on the last slide of that SAPS report. So when we receive the link with the presentations, please let's refer to the last slide, which is giving us a response to the reasons for underreporting. I do want to believe that the slide is just based on observations and maybe what is this, FCS, domestic violence or gender-based violence, observations from an M&E point of view. We should then be able to have those answers. Again, Naledi had asked a question posing, or rather prompting us to look at, I think mainly Department of Social Development, when are we going to start seeing indicators or rather statistics that points to the prosecution of parents due to neglect, because we are just referring here to the perpetrators, and we do know that the survivors or victims will in some instances point to a relative that was actually aware that a violation is happening, but then that parent or guardian choosing to keep quiet and to look away. And I think now the conversation is advancing at holding parents and legal guardians accountable insofar as reporting them to law enforcement. And I hope that on the NSP, or rather on the strategy by Department of Women or UNFPA, we may want to say something when it comes to this, because there is nothing that is happening in our families that our families are not aware of, but they choose to use other mitigating means to try and to address the issues, which is really totally against the law when it comes to children. And lastly, colleagues, as we put our hands together for Commissioner Samai, I do want to just ask us to just remain seated for a minute so that we can just get to the last lap of our presentation, which is the way forward and closing remarks. Thank you, colleagues. We may all welcome.
Afternoon, everyone. I think I have the graveyard shift. But Molweni, goeiemorgen, good afternoon, sawubona, assalamu alaikum, shalom. Namaste. I think fellow commissioners, representatives, it's just a pity the young people are not here. The young people in this room whose lives and futures have been at the center of everything that we have discussed today. I just wanted to quote, and just so that everyone has an inherent dignity and the right to have their dignity respected and protected. I think we need to be able to center this, and I think also center it in terms of Ubuntu, that my humanity is bound up in yours, for we can only be human together. And so we chose to call this gathering an Imbizo, a dialogue. Deliberately, it's a dialogue. It asks us something specific about us, that we listen as much as we can speak, and that we leave changed, not merely informed. It is that in that spirit that we today, above all, been at hard work. But the most important issue is, it is in the spirit that today, above all, being a hard look in the mirror, not all about the girl, but it's also about us. We have spent too long asking what's wrong with her. Today we need to ask what conditions have failed this child, and what must the state, the family, and the community, and every institution in this room do differently. And that is the question that the dialogue must be remembered for. So just key resolutions, there's obviously much, much more. We resolve to treat a pregnant child as a child first. A 10 to 14-year-old who is pregnant is not a teenage mother. She may be a survivor of statutory rape, coercion, exploitation, abuse, and our systems, health, education, social development must be coordinated enough to see that, investigate it, and protect her without ever forcing her to relive her trauma through a system that was built not for her or for children, but for adults. So we also resolved to put consent, and I think that the Commissioner Namataheni indicated. So this is central to bodily autonomy, at the center of everything we do. Consent is not a box to be ticked. It is shaped intersectionally by age, power, poverty, fear, and dependence. So every adolescent, and I think we've heard what the UNDP has indicated, not teenagers, adolescents, has the right to accurate, confidential, non-judgmental information, and no child should ever be forced to continue a pregnancy, forced to terminate one, or be denied the lawful care she is entitled to. South Africa is not short of laws. Our constitutional, our National Act, Children's Act, Choice on Termination, SOMA, these are all strong instruments. What we lack is the translation of that law into a genuine lived capability to choose. A right to contraception means nothing to a girl who cannot reach the clinic. A right to remain in school means nothing if there is no support plan waiting for her when she returns. And so it is a social and institutional responsibility, and we resolve that care is not private women's work. When a young mother goes back to school, somebody cares for a child, usually a mother, grandmother, gogo, always a woman, always unpaid. If we are serious about caring, society, the state, the school, the clinic, and the community must carry the weight with her and not leave it entirely on the shoulders of other women. We resolve that no learner is ever expelled, humiliated, or quietly pushed out because she's pregnant. The right to education does not end at conception. It continues through pregnancy, through birth, and long after. And so we resolve that this cannot remain a conversation about girls. Where are the boys? Where are the men? Prevention that speaks only to girls leaves accountability nowhere to land. Boys and young men must be brought into this work on consent, on responsibility, on gender norms, and older men who exploit children must face the consequences. Never silence. And so we resolve to also confront conscientious objection, which the Department of Health have slightly indicated, where it becomes an obstruction. No personal belief held by a health worker in the state may be permitted to delay, deny, or obstruct a girl's lawful access to reproductive health rights. Whether objection exists, an immediate effective referral must exist alongside it. Nothing less is acceptable. I am of the opinion that conscientious objection is unlawful. A gender-based violence and feminized lens, which I think was discussed. We must also be honest about what a portion of teenage pregnancy actually is, where a child is impregnated through statutory rape, exploitation, or abuse of power. That pregnancy is not a parallel issue just to gender-based violence. It is gender-based violence. It is rape. And it must be named, reported, and resourced as such. Seeing it this way is not theoretical. It is what allows us to anchor everything resolved here today in an instrument government already carries a mandate for, which is the National Strategic Plan on Gender-Based Violence. So I've taken out 3 of the 6. Prevention and rebuilding, which we all know is 2. Bringing boys and men into consent and gender norms, and confronting practices like ukutwala that dress coercion up as culture. Then also prevention 3, which is one of my favorites, justice, safety and protection. The coordinated identification, referral and protection of children under 14 where pregnancy may indicate statutory rape or abuse. Economic power, breaking the cycle where interrupted education becomes a lifetime of economic dependence. Access to grants, documentation, and a genuine route back into education. This dialogue cannot end with another compact that gathers dust besides the last one. It needs architecture, a structure with named owners, timeframes, and consequences built around the 3 pillars above. And I think that was called for. Coordination, a single name interdepartmental structure sitting with an existing GBVF accountability architecture, not a new parallel body. Bringing together all of these, and we know it's a JCPS cluster. We do know that there is a development committee. We do know that there are various structures that will be able to pull this together. Within provinces and municipalities, traditional and religious leaders and civil society sit inside the structure, not outside. And adolescents themselves have a standing seat in nothing. Nothing about them should ever again be decided without them. And here I'm talking about all that structures that we know. The gender-based violence structure, which is the intersectoral, the VEP, the children's structures, etc., that all sits on provincial level. And that sits within the JCP and sits within a development committee. Each department reports on its own resolutions, and so we need to look at the number of adolescent mothers retained in school or reintegrated with a functioning individual support plan and their access to grants and documentation. Where a department does not report or reports without evidence, this commission will say so publicly to this dialogue when it reconvenes to Parliament and to the relevant provincial legislatures. Silence will not be read as compliance. This is not a request built on assumption. The Commission's own 2023 report. We have been doing this work since 2020 and 2023 and prior. Learner pregnancy policy interplay, school dropout of adolescent girls during pregnancy and in the postpartum period. Put this failure on record. And in its own response to that report, the Department of Education itself acknowledged that many schools simply do not develop or implement the individual support plans to recognize or to learners. That is not our finding alone. It is the department's own admissions. So non-compliance of this kind does not merely bend the policy out of shape. It defeats its entire purpose. And it is a direct contributor to dropout rates. So when we speak of a closing the gap between policy and implementation, we are not speaking in the abstract. We are speaking of a documented, acknowledged failure that now requires a documented, monitored correction. And so in the coming period, the Commission will table also our Northern Cape Teenage Pregnancy Hearing Report. I want to flag this because it will test everything we have resolved here today. That report will show what we have already suspect, that even where the numbers have declined, they remain far too high. And that decline on its own is not proof of success. A failing number sitting on top of an unimplemented policy is not progress. It is a warning that the gap between that we have legislated and what a child in Springbok or Doar or in Kuruman can actually access has not closed nearly enough. So that report must not sit on the shelf. It must return to this dialogue, to Parliament, to provincial legislatures, and to departments named in it, with clear questions about who is responsible and where will it change. So we came together with a clear conviction that teenage pregnancies is not a moral failure of a child. It's a test of a society, of whether our institutional protection, whether our systems of care and whether our rights, so carefully written in our constitution, actually reach just the child who needs them most. So the Commission has looked at today's evidence, I would say, through an African intersectional care feminist lens, because a girl in the Northern Cape does not experience pregnancy the same way in a girl in an urban center does, and neither of the experiences can be understood apart from a race, poverty, disability, geography, and gendered power. That lens does not ask us to admire our own principles. It asks us to build something concrete, a capable state, a state whose departments are coordinated rather than siloed. And a capable state is one where an individual support plan is not paperwork gathering dust in a filing cabinet. If we take that lens seriously, then care cannot remain invisible. It cannot remain unpaid and carried only by women and girls. It must be shared by the state, by families, by communities, by all of us. And so let this dialogue be remembered not for what was said here, but for what changes it will leave or when we leave this room. So from rights on paper to rights in practice, from stigma to dignity, and from exclusion to reintegration, from a girl's private burden to our collective responsibility, and from falling number that comforts us to a number that is still too high to accept. No child should be blamed for what was done to her, and no young mother should be abandoned by a school or her clinic or a state. No survivor should be silenced, and no adolescent girl or boy should be denied the information, the protection, and the future they are entitled to. That is the standard the Commission of Gender Equality sets for itself today. We will return, and we will hold ourselves and every department in this room accountable. I thank you. Malibongwe.
All right. Yeah, what a profound way forward. Really committing to the cause and ensuring that accountability is really at the center of what we should be doing moving forward. With that way forward, thank you very much, Commissioner Samai. The call is clear. I do want to believe that it has really landed to the correct heads where action needs to happen. And I then am forced to end it right here without really adding much to what you have put out. And colleagues, I also want to really thank yourselves for staying with us throughout the course of the day. I do acknowledge that we are actually having this engagement alongside a very busy, schedule of the Women's Month. And we really understand how demanding and how committed the diaries are. But we really want to thank you for taking your time and really dedicating your Monday towards this Imbizo. With that said, colleagues, let's really put ourselves at the end of it all and thank ourselves for being a good audience, thanking the ones who are also online, the ones who are taking this engagement or rather this Imbizo from their phones, spending on their data, and those who are still sitting in the offices really listening to the proceedings of the day. And with that said, colleagues, I am now officially bringing this program back to the head of research, the biggest boss for this program, and over to you, Dr. Oveni. I should think if we were to talk gig economy, my gig actually ends here. Thank you.
Thank you, colleagues. I don't want to say a lot. I just want to thank the program director. She was so excellent, so patient, so insightful. So mine is just to thank you for supporting us as always.